shortly after this meeting. Commissioners, as you know, you have the ability to mute and unmute and the option to be on video, and we do appreciate that you're on camera whenever you can be. Please do mute yourselves when you're not speaking to reduce background noise. We'll leave it to Secretary Galley in terms of how to invite conversation, but should you ever want to be put in a queue, feel free to use the raise hand feature, which is first the happy face reactions icon at the bottom of your Zoom screen. And then if you click on that, you'll see the raise hand feature. For members of the public, thank you for being here. You can listen to and view the meeting. We'll have a public comment period before the meeting adjourns, at which time you'll have access to the chat feature for written comment. You may also email your written comments to healthycaforall@chhs.ca.gov. And we will also be opening up at the comment period a chance to speak your verbal comments, and we will point you to the raise hand feature at that time. All public comment provided today will be provided verbatim in a transcript and posted to the webpage as well a few days from now. All right, I think that covers it for me. Secretary Galley, I'll hand it back to you. And I do see that Rupa Mario is joining us now.
Great, good to have Rupa with us. So first, we're gonna get right into it in a moment, and I'll introduce our invited guest all the way from the East. So I first wanted to just say that I think I got a lot of great feedback about our meeting last time. I think people enjoyed the open conversation, that each commissioner had a place in the discussion, and we're gonna keep trying to do that more and more. So today in sort of my facilitation role, I'm going to not drive harder, but really try to guide the conversation, pull each of you in at places where I know from our prior conversations there might be a point or a thought or a question you might ask, and I don't always get it right, probably get it wrong most of the time, but will do my best. I know people will raise their hand periodically, and I might not always jump to the person with the raised hand for the sake of having some flow to the conversation. No disrespect intended. I really hope to get people in throughout the conversation. There's a number of you all have such important things to offer that I'm never gonna get it all right. So forgive me in advance, but I will try. And then I think the last thing I would say is we wanna be mindful about how long we each end up speaking. I think we generally have different styles of presenting. I want to honor those different approaches and styles, but want to keep the conversation going, because as I reflected back on our last meeting, if I could have gotten a few more comments in, connected a couple more dots, I certainly would have felt even better about it. So I'll try to do some of that today. So excuse me, and please feel free to give me some feedback one-on-one afterwards if you feel like I can do a better job keeping us towards our goal and ultimate focus. So before we get into the sort of core of the conversations, and we're gonna have two today. The first part is really gonna be what I'll call wrap up from our last meeting a little bit, which is Bill really spent a lot of time on the Taiwan model. We didn't get as much of a chance to talk about the really interesting paper and experience in Vermont. And that's why we'll spend our first bit of time with Governor Shumlin. Pete Shumlin's joining us from the East. We had a nice prep session to talk about how we get to the meat of it quickly. So thank you, Governor Shumlin, for being with us. The second part of our conversation is really going to be one where we'll have a panel. We'll have three invited commissioners to share 5 or so minutes each. We have Peter Lee, Sandra Hernandez, and Anthony Wright all teed up to share some thoughts, and then we'll go into a full commission conversation about how we, in a unified system that we're aspiring to create, how do we achieve accountability? How do we use some of the tools that we have in place today to build on which ones work, which ones haven't been that successful? Rather than have this juxtaposition about intermediaries, let's talk about some of the attributes of systems that we can use, build upon, bring anew, that allow us to achieve the things I know run deep to so many of you, all of you on this commission. But before we get into that meat, I wanted to talk about something else that has been important, and that's been the community engagement, community listening opportunity that we know is important to this conversation. We don't believe that we can guide the policy of California without listening to the people who make up California. And the whole concept that nothing to us without us notion is one we want to build upon. So I just want to thank Antonia, Bob, and Sandra and their foundations for agreeing to put together a related conversation on community engagement, listening. We'll hear more about that and the plan for a September webinar. At our August meeting, I'll dedicate a few more minutes there, but because some of you appropriately raise it and wonder where we are, I just wanted to say it's moving forward, and we will talk a bit more about that in detail in August. If you have independent questions on that in between now and then, feel free to reach out to me directly or Vishal, who is also on. So with that all in place, I want to, and amazingly ahead of schedule, according to that little sheet I have in front of me, and really I'm trying to get to conversations quickly to get all of you dialoguing and going back and forth a little bit. But with that, Pete, Governor Shumlin, thank you. I'm going to turn it over to you in just a moment, but you know, you were governor of Vermont at a very visible time in Vermont's healthcare history, 2011 to 2017, after I know decade, at least, I don't know the exact number of years in their legislature, really guiding and leading on issues around health. And you were governor at a time when the state was promoting a single payer model, and you took a swing at something that almost no one else has ever done in our country. And we want to hear from your experience. We want to understand it. Last month or a couple of weeks ago, we had the pleasure of having Professor Shao present his contributions to both the Taiwanese system and a bit on the Vermont system. After you spend some time with us sharing some thoughts, we'll also have a chance to dig into the reading, the required reading that Bill shared with all of us in advance, which Governor laid out the white paper that he and others put together that laid out 3 options that I know were important to the thinking, not always every last detail, but important to the thinking of what Vermont looked at to do. But we really wanted to hear a bit from you to start, what it is that Vermont tried to do, why you tried to do specifically that, what the inputs were, and then 2 other important questions that I'm sure you're asked frequently. One is, well, what was missing that didn't allow you to get to the finish line? And what might you do differently, if you will? And I know you shared one really important observation yesterday that I'm excited for the commission to talk about, because it's related to something else that's on my mind this week and has been for months, which is affordability and our thinking about healthcare affordability and creating an office potentially here in California. And then the second question, sub-question to that is, well, we know that there's a lot around federal permission and federal collaboration, and people talking about waivers and whether you need them or not. It would be terrific just to hear a little bit about Vermont's experience with that. I know a different time, different environment, different administration, different national expectations, but I think that is something that will rear its head in our conversations, and it'd be great to get your advice and experience on those things. Without further ado, I'm going to turn it to you, and the floor is yours. I know you don't have a ton of time with us, but we're excited to get your comments. And again, thank you for joining us.
Thank you so much, Secretary Galley, and to all of you commissioners. My hat is off to you. I'm here to help you any way that I can. I'm delighted. I know I've met many of you, and it's great to see you still working at this cause. There's nothing more important except for climate change, but these are related, as we all know. And I got to give a special shout out to my friend Bill Shaw, who I turned to early on, about where you are right now, when I was president of the Senate and I was not yet governor. In fact, I didn't necessarily expect to run for governor at the time. And I said I'd heard about Bill, I'd heard about Taiwan, and I was lucky enough to get him on the phone. And I called him, and I just have to tell you this story because it'll make you chuckle. And he goes, "Hey, nice to talk to you. I wish you all the luck in the world." But he said, "I've given up on America." And I said, "Yeah, well, just hold on now. I want to tell you why Vermont is not America." And so we had several subsequent calls, and the conclusion finally was, much to my joy, "Okay, you've convinced me that Vermont's not America. I'll take a crack at this." And the only reason I'm telling you that story is California is not America either. And I actually think that you've got a better shot than anybody. So it's why I'm so excited to be a part of this. Now, I don't want to talk a lot. I really want to answer your questions. I'll just help because I think the secretary laid out some good sort of overall big picture thinking, and I want to share it with you. But I really want to hear from you and answer your questions. Listen, we're having to be talking about the biggest disappointment of my.
Governor Shumlin, you've muted, sir.
Is that better?
Yes, thank you.
Yeah, it just freaked out on me, the system. I didn't touch anything. I just want to say that that what I was saying was that, governors do a lot of things. I did a lot of things I'm really proud of. This was the biggest frustration of my years in politics, was not being able to succeed at passing a publicly financed single-payer healthcare system where healthcare is a right and not a privilege. It doesn't mean I didn't try hard. What's the background story? It was 2010. I think I was the only gubernatorial candidate in America running on single payer. I mean, I literally said, if you elect me, Vermonters, I'm going to try my best to get this done. We got a lot of work to do. There's a lot of obstacles. I laid out a lot of other things in my platform that had nothing to do with single payer, but I said, I'll give you my word that I'll work as hard as I know how to get it done. The obvious question then that you should be learning from is, why didn't we? And as I mentioned to the secretary yesterday, in politics, as you all well know, there's two factors: the things you don't control and the things you do control. And let me just outline first the things you don't control, and then explain things I did control and why it was so tough. Don't control. So let's remember that when I ran for governor, everyone was running on jobs, biggest recession in American history, everything's crashing. And I connected jobs to economic prosperity, as I'm sure you're doing, quality of life, and most importantly, our economic stability as a state. We all know that we spend more than anybody else in the world on healthcare. The outcomes are much lousier than everybody else in the world. That if we're all living to 200 or even 140, or frankly, even if we had healthcare outcomes that proved that we were going to live longer than our parents, it might be worth the investment. We all know that's not the case. We spend crazy money and we have higher infant mortality, higher lower lifespans than many countries spend a lot less. So we know the money that we're spending is crazy. So I made the argument, hey, we're going to fix this system by having it be a right, moving it from an employer burden, and having a more sensible system. Remember that Obamacare passed the year I came in. And by the time we did the work to answer the secretary's question, worked with Washington, worked with the Obama administration, got all the waivers worked out of what we were going to have to waive and what, frankly, we were going to subvert in the federal process that kept us from getting to a publicly financed system. By the time we got there in 2014, 15, the midterm election, the 2014 elections had happened. Democrats got killed. The Republicans took over Congress. They'd already taken it over, but they took over the rest of Congress. They did it on what? They did it by running against Obamacare. Also remember that Democratic governors who embraced Obamacare built our own exchanges, as did the president. And Republican governors had the good fortune of saying, we're not going to do that. We don't even like Obamacare. We're just going to go to the federal exchange. So what did I do? I went out and hired the same contractor the federal government hired to build their exchange. You know what happened with that. The same thing happened with mine. Governor Deval Patrick engaged the same contractor. His failed. So here we were saying, as I was saying, as a governor, hey, we're going to revamp the entire healthcare system more sensible. I couldn't build an exchange that worked. And remember, my challenge was higher than anybody else because Vermont reimburses, we chose to reimburse at a higher level than the federal exchange. So our exchange had to check your IRS records to make sure that you were telling the truth and confirm that. Then check the Vermont state tax records to make sure you were telling the truth and confirm that. Twice as hard on building the exchange. It was a dismal failure. And by the time I got it fixed, fired my contractor, as did Obama, and bring in a new contractor, my credibility around healthcare had tanked. The obviously Republicans were simply saying, if this guy can't build an exchange after he's promised you he's going to, how the hell is he going to rebuild your entire healthcare system, move it from premiums to taxes and all of the rest? So you can understand those are the external factors that I was up against. Internally, what was my challenge? Man, this is a tough job, and you're about to find out how tough it is. I think it's much tougher for a small state than a big state. And I'm not going to list for you all the reasons why it was so tough, but I'm going to give you the main one that I learned most quickly that was most surprising to me. Not surprising, but which I should have anticipated and articulated better to Vermonters. I said right from the beginning, and it was because of Dr. Shao's work and then the work that we did subsequently. And by the way, I know that you've shared Dr. Shao's report. I encourage you, if you can stand it, to read the 107-page report. Dr. Shao's report came down in 2011. In 2017, we issued the healthcare financing plan analysis. And I believe it's January 24, 2017. It's actually prepared by my agency administration, but it was published by the UMass Medical School, where they were involved in getting it out there. Definitely get that document and read it if you can stand it, because it will really help you understand some of the things you got to figure out with Fed and state relations to make this work. But having said that, put in plain English, the biggest challenge, when I had my financing plan together, which was pretty much based on what many of the recommendations Dr. Shao had made to us years before and some additional, we were basically using an income tax and a payroll tax to fund the plan. I also made the decision to make it all inclusive. Now that's tougher for Vermont than it is for California, because remember, we're a teeny long state with very few people. So we have New Hampshire on our east, we have New York on our west, we have Massachusetts on our south, and we have Quebec on our north, who has a great healthcare financing system. So lots of people live in New York, in Massachusetts, in New Hampshire, because we're such a little narrow state, and live in those subsequent states. And I said to employers, hey, we're going to get healthcare off your backs. But I couldn't say, we're going to get healthcare off your backs, except for all of your out-of-state employees, because then they were going to have it off their backs, but then have a smaller plan for their out-of-state employees. I mean, that's a bigger pain in the neck than running a plan for everybody, right? So we had to include everybody. It was all inclusive. That drove up, obviously, the cost. But the biggest challenge that I had in the end was that as I came up with a financing plan, the obvious question was, you're going to get your one-time savings from moving to a much more sensible financing system. And I just want to emphasize that our savings will be less acute than yours in California. Why? We have no for-profit hospitals. We're entirely nonprofit in Vermont. We basically have 1.5 insurers. In other words, Blue Cross Blue Shield, the nonprofit, is 80% of Vermont insurance, and there's a bunch nibbling around the edges. We had passed community rating, we invented it. So we'd driven out all the for-profit insurance companies that wanted to come and grab the young, healthy people and leave the old sick for everybody else. We've done all those reforms already. So my point simply is, we were still experiencing healthcare cost increases that were 2, 3, 4 times of our income increases. Just like America, our premiums would go up 10, 12, 14, 20% a year. And even my most progressive legislators, we have 3 parties in Vermont, Republican, Democrat, and Progressive. And the progressives have always been the main driver for single-payer healthcare in Vermont. I joined them, but they were hugely helpful to me. But even my progressive senators and legislators were coming to me behind closed doors and saying, do we really have to do this all at once? Couldn't we find a better way to get there slowly? Are we really going to have to raise taxes every year at the same level as healthcare insurance premiums, less the one-time savings we get for going to a more efficient? And I said, yeah, that's why I've been fighting so hard and did, that the press never wrote about because they couldn't understand it, get the first waiver in America that allows us to move the entire state of Vermont from including Medicaid, Medicare, the whole package, from fee-for-service to an outcomes-based payment system. And I'd lined up, believe it or not, the CEOs of my biggest hospitals, UVM Medical and Dartmouth Hitchcock, because that Dartmouth Hitchcock in New Hampshire is 40% Vermonters. And they were on board in moving us from this crazy fee-for-service system that basically encourages providers to keep providing care. And in a rural state where we have so much Medicaid, Medicare requires you to keep billing, or you go bankrupt. You get 40 cents from $1 phone pay, or you get 60 cents from another. Every once in a while, some sucker comes to the door, has to give you $1 for $1. You know how the system works. We have so many rural community providers that they were like, we're on board. We know we go bankrupt under the current system. And we got a waiver from the Obama administration that allowed us to move from fee-for-service to outcomes-based payment. We set up this curriculum, we found healthcare board, the regulatory folks, but it's been a huge lift. And a Republican governor that replaced me, everyone thinks Vermont's super liberal, blue, and we all are Bernie country. But the fact of the matter is, we change parties every time we change governors. So you can pretty much be governor in Vermont as long as you want, if you're crazy enough to keep running. Just don't forget, New Hampshire and Vermont have 2-year terms. So I was a 3-term governor, but that's only 6 years. And my wife said, if you run again, it's you or that. You know what I mean? I mean, no sane person would do it 4 times, although there are a few that have. My point is, legislators realized that we had to get cost under control, because with the current system that you have in California and we have in Vermont and we have in America, where we're spending money like a bunch of drunken sailors, 3, 4, 5 times the level of our income increases, no system, single payer, multi-payer, unless you're going to mint money, which is illegal, you're not going to be able to support this healthcare system under any payment system. And that's, I think, was my biggest takeaway, and why I worked so hard to simultaneously move to a single payer, publicly financed system, while we found a way to deliver better, healthier outcomes, where the incentive for the provider would be, you keep this person healthy and you get more money than if you do the current system where you keep them a little bit sick, but you're screwed if they're dead. So that's just some food for thought. Happy to answer any questions you might have.
So, Governor, you answered certainly the questions I posed to you. So thank you for that. I want to see we pull in a few folks. I was hoping we'd have Assembly Member Wood on by now, because I know
he's been stuck with me before, so let's have some sympathy for him.
Yeah, no, he wouldn't describe it as stuck. I know he's on a different floor dealing with a different issue as one of our legislators. Anthony, I know you're going to present before, but I know you've been part of the conversations with Governor Shumlin before. Are there any specific things you want to sort of focus on and have Governor highlight that maybe he brought up before in prior conversations that you thought were important for Californians or the commission to hear?
No, I thanks for calling on me again, Secretary. The Vermont experience is just instructive in a lot of different ways. I had a chance to talk with one of your aides, Robin Lynch, on occasion, as well as with you, and I appreciated that. I guess I would want to hear more about just how you think things have evolved with regard to the state-federal relationship, which I know looms large as a question, and how that has evolved since we've gone now. We do have different administrations, and the work around efforts have evolved as well. And then also just, I know I think there's the issue of the big state versus small state. I think my understanding is you have two big systems on different sides of the mountains. And we have a lot more diversity within California, which is both our strength, but also something we have to then deal with. And I think, again, these are solvable problems, but I'm even just curious how you dealt with the two systems that you had and how you had to deal with them in different ways.
Sure. So let's just first go to the federal question. Listen, you all know that most of your healthcare money comes from the federal government, not from Californians. When you actually look at the pie, where the money's coming from. I had the same challenge. You cannot do this without a sympathetic White House, period. So what I said to Anthony and to others when I was testifying during the beginning of the Trump years is, listen, I hate to break it to you, but I think that you can do a lot of the groundwork now, start to work on cost containment, figure out how you can move that ball. But with the Trump administration, if you think you're going to get the cooperation you need to do a single payer his system in California, and you know something about President Trump and Mike Pence that I haven't learned yet. President Biden, on the other hand, I think that you are in an extraordinary position to move forward. So this is the time. In terms of the federal challenges, if you read our document and talk to, in particular, I'd urge you to talk to Dr. Anya Rader, who, when we gave up on single payer, she was Gina Raimondo's main healthcare czar. Gina, as you know now, is Secretary of the Treasury. She then went to Brown University. She's now back up at UVM Medical. She's a Vermonter, but she is as good on healthcare policy when you get into the weeds of how to get this done in California of any individual I know on this earth. Having said that, she can walk you through kind of, and when you get into the detail, what you got to do, because the details is where you die. The details is where you die. It's easy to give the single payer speech. My job was easy, but trust me, this is tough stuff. But she can direct you to the challenges to what you specifically need to get from the agency, from what you need to get from the president of the United States, and she can tell you how you get around the stuff they can't give you. What's that? Let's talk ERISA. You've all heard about ERISA, and everyone says, oh, you can't do single payer because of ERISA. You got a lot of ERISA employers in California, more than I had in Vermont. They are your biggest challenge, along with the specialists who are making a lot of money and the insurance companies and the pharmaceutical industry. How did I get around ERISA? This is how I elegantly designed our plan, because they were all screaming and hollering, and we don't want to know IBM and the rest rolling me in. We don't want to do this. You're terrible. You can't do this. You're going to kill us. We're going to move out of your state, all that stuff. Listen to what I said and finally did. If we'd done our plan and succeeded, I simply said, keep your ERISA plan. First of all, we have no control over your ERISA plan. And secondly, who would I be to get in the way of what you're doing? Go for it. But I just want you to know I'm using the payroll tax and the income tax to finance this plan. And your employees and you are going to be paying that. So if you want to pay twice, be my guest. That's your decision. That's how you deal with ERISA. I can tell you that those companies aren't going to take 15 minutes with their CFO before they come running to you saying, hey, now how do we get our people into this plan exactly? So that's how you deal with that challenge. There is a way around every problem. But I got to tell you, the bigger challenges are having a really good team, implementation team. It took us 3 years, and that's why I urge you to read the 107-page report of exactly what you need to get from Washington, how to get it, and how to move forward. What was the other part of your question, Anthony? I missed it, or I forgot it.
Well, just you have dominant providers in both sides of your mountains, and I guess the question is, at the end of the day, they are the main provider in the region that they dominate, right. And so how well can you negotiate with them and deal with the specifics of them, given that they have their own dominant power against the the dominant power of a single payer financing system?
You know, I think an advantage that I had, I don't know enough about the individual players in California, but I'd be happy to help try to figure it out with you. I had enough big players in Vermont who realized that they're in huge trouble in the current system, that when they look at the sustainability of the current model, they don't think they can do it. And I bet you'll find that when you dig into the weeds with the providers in California, you're going to find where your allies are. Now, are you going to have enemies? You bet. But what I did was coalesce enough of the allies so that when the folks who were really convinced that this was a terrible idea would articulate that, and that came from the big businesses, the ERISAs, some of the specialists, and you can imagine who, the other team was saying, hey, wait a minute, though. And I happen to have, some pretty big players who are willing to speak up and say, we should let this happen. We should let it play out. We should at least listen and learn and help. And that's got to be your first step. I put together a pretty broad coalition of business people, insurers, and others to help with the building of this system. Now, a lot of them were using that knowledge to knife me in the back when I walk out the room, but others became a part of realizing this has got to happen. So, I cannot advise you because I don't know enough about your players, but in the end, this is how America is going to go. When I look at the big picture, sort of how could you, as the 5th largest economy in the world, drive it in ways that the little governor of Vermont couldn't? I would say that you might not have to do the whole thing. And what I mean by that is, if California, the biggest state in the country, gets enough momentum so that you're about to move to a single payer healthcare plan, don't you think that the political fallout from that would be that a whole bunch of Democrats in Washington would go, hey, wait a minute, we've already got a single payer healthcare plan. It's called Medicare. Let's just get rid of the age discrimination, fix some of the other challenges in that, and we can do this with California, but we can get the other 49 states while we're at it. So I think there's a lot of reasons why you could be incredibly powerful in pushing this forward, even if you don't get all the way. Now, I wouldn't say that as a grounds of getting it done. I would say that there's no state in America who could move this issue more powerfully than you.
So, Governor, thanks. I want to pull in. I see 2 hands up, or I see 1 up, 1 down, was up in Richard Pan and Bob Ross. But before we get to you 2 and Sandra's hands up now too, I want to pull 2 people in. Andy, I want to sort of put you on the spot about some of the federal engagement pieces. You and I have talked about how hard that is, and kind of what's your reflection about what Governor Shumlin said, and kind of the reality of that piece in your experience. And then Don, want to pull you in on some of the employer piece, and just thinking about how do we, Peter, you put it in a way that, I hadn't heard before. I'm curious what other people's reaction is around some of the how to deal with ERISA. And Don, I'll put you on the spot on that, and then we'll go to the hands. So Andy, do you want to go first?
Thank you. So the governor is spot on the issue of federal dollars being central to any solution here. And, my own background is in Medicaid, but there are even more federal dollars flowing out of Medicare. And I guess my question for the governor is, as he was proceeding to work with, hoping to work with a friendly administration, how did you approach the question of Medicare, getting control of the Medicare funds and getting control of the Medicaid funds, because they're really 2 different problems. And I don't think the waiver authorities, as they are now constituted, are quite adequate to a state capturing both of them. So I'm just curious as to what your workaround was on that front.
So we got a 511 waiver, whatever you call it, which basically allows us to take our Medicare and Medicaid and pool it into our all-payer waiver. So I know I'm speaking globally here. You got to talk to Anya to get the specifics, but we got the waivers before we brought up the single payer thing with the feds. In other words, we said, we cut a deal with them where you give us the money, we're going to manage the money, but we get out of the other requirements that many other states have around constraints on Medicaid and Medicare spending. So once we had done that and gotten those waivers, when we went to them on single payer, which we did simultaneously, we simply were incorporating the same benefits as Medicare into our plan for all Vermonters. So they were like, well, as long as your plan isn't reducing benefits, we're good. Now, that's a very gross generalization of a much more complex answer to your question. And my policy people can tell you exactly how we did that, what waivers you need, and who you got to see to get it. But we couldn't have done it. We have, I mean, if you think it's a big part of California, we're 60, 70% Medicaid, Medicare here. We couldn't do a single payer plan without incorporating everybody in. Everybody in.
I mean, it's helpful. And I think this is something we're going to dig into a little bit more down the road, and these permissions that we would have to seek, the potential of getting them, et cetera.
I mean, yeah. The only thing I'd say is you guys don't have time for that. Hire a good staff and have them go do it. You know, you all, if you go get into the weeds on this stuff, you're dead. You got bigger problems than that.
Yeah, no, we agree. I in particular agree that we'll need a team to get that done.
I can help you. I can help you with some really good team members who've done this before that you don't have to teach them all over again. And I'm sure Bill can too. Beautiful.
We'll take you up. Don, putting you on the spot, and then we'll go to the hands. There's a few more up.
Sure. Yeah, you know, if the question, I think part of the question was this question about ERISA. You know, that's a tough one. You know, what I can say is I think the approach Vermont took is not dissimilar in spirit to the approach that we took with SB2 and later Prop 72. You provide options, so you aren't compelling, and the fact that that some of the options naturally lead you to be more supportive of the approach is not your problem. We, as you know, that bill passed but was referendized, so we never made it to what we anticipated which was a fight at the Supreme Court. I don't know how that turns out, particularly with this court, but I think at the end of the day, you craft the best policy, you look at how it fits in with ERISA, and you run with it. There's not really, I'm sure an ERISA lawyer will have a much more sophisticated answer. On employers and support from employers, it also, the approach the governor was laying out, very similar again to what we found with the health reform in California in the early 2000s, where among the employer crowd and the provider crowd, all the way down, you're going to find support just on principle, and you're going to find opposition on principle. And then within that, you're also going to find support because there are always winners and losers whenever you change the rules. And working with the winners is never a bad strategy. So, in our instance with SB2, it was the large union employers who were already providing benefits that, for the most part, fit the requirements of the bill, who were competing with large non-union, largely employers who are not providing the same level of benefits, and they were losing. They were losing out competitively. It cost them, I think the line was, an extra dime to put a head of lettuce on the table, and all things considered, they'd rather have their competitors required to do exactly what they were doing voluntarily. So you can always find support that way and build on it. It's tough. The association politics make this all very tough. So we got sort of silent support in California among the employer community that was quashed pretty quickly by the larger coalitions of employers, but it was real support. So I do think, I do think it's out there. I think the other thing that's interesting is, smaller employers who pay disproportionate percentage of payroll, who don't have the leverage to get better deals on healthcare, et cetera. If you craft a good option for them, it's going to be attractive. So just a few thoughts.
Yep.
Oh, Don, thanks. And I think this winner loser issue and how you balance that, and Governor, you said it to me clearly yesterday, don't want it to get lost on folks, just the affordability question. Managing that kind of probably narrows the range of what the winners have at stake and what the losers have at stake. And so a key principle that you raised as something material that you would have certainly said, hey, we'll pass it now, but it doesn't go into place, doesn't actually take shape, single payer, until we get the cost increases under control. I want to get, we have 15 minutes. I bet there's some rich questions in our 4 folks with hands up. So I'm going to go to each of you in order. And then I want to make sure we leave a little time for you, Bill, to, I'm going to have you be the bridge again. I think we have an exciting conversation teed up next after our break. But what sort of in the way you thought about it in 2011 for Vermont, what were some of the attributes of the system that you felt were most important in Vermont that California should lift up, just like you did in the Taiwan conversation? What are some of those attributes? Because I think that might help us build into the next part of our conversation. So Richard said, Senator Dr. Pan, go for it.
Thank you, and really appreciate your presentation, Governor. So I'm a physician. Actually, interesting enough, talking about contrast and sizes, I believe my Senate district is actually larger than the entire state of Vermont in population. I represent over 1 million people. And certainly understand different dynamics.
We'd have to count all our cows to catch up with you.
There you go. So I'm going to ask since I'm an elected official, I am going to ask the political question, because you did make mention that even your progressives came to you and said, do I have to vote for a tax? And sometimes in these groups, everyone's like, oh yeah, no problem. It should be easy to get Democrats or so forth, progressives to vote for taxes. But, this is also the land of Prop 13. If you want to stay an elected official, you got to think really carefully about imposing taxes on people. So in terms of your experience, and can you just elaborate perhaps? I know that in the end, unfortunately, the stars didn't align. I mean, I will point out that you talked about the exchange and the challenges of the exchange undermining your credibility. I'd point out here in the state of California, we couldn't even deliver vaccines without having, hiring a private intermediary, Blue Shield, to do that, right? The state itself couldn't do that. It's on its own. So some people may raise questions about that, about the state's ability to be able to deliver a whole healthcare system. So those things will always come up. We can argue whether they're real or they're more facetious arguments. But can you speak to the perhaps some of the political challenges? I mean, the prospect of having to ask your legislature to raise taxes every year, to a certain point, right? Et cetera. So, I mean, how close were you politically to making this all happen? I guess.
Yeah, I mean,
that final mile is always the hardest, right? You can always lead right up to it, but that final bit, right, is always the hardest to get people to finally cast their vote. Yeah.
If I hadn't gotten caught up in the unpopularity of Obamacare at the time, don't forget it was unpopular before it was popular, which is why the Republicans couldn't repeal it. But I was there trying to do this in the trough, when even some Democrats, you may recall, were going, why did we do this Obamacare? No one had the benefits at that time, and they only had the hassles. So that all shifted for good reason. Having said that, listen, we all know that we're paying for healthcare. We're paying the healthcare tax every single day. Businesses hate it. My business is a great example. I'm a business person. We don't want to deal with it. I have to have employees who do nothing but this junk. Every year we pay more and more for commercial insurance that gives you less and less coverage. I mean, the stories abound, right? So you know,
Governor, I'm going to push back on you just a little bit right now, because as you said earlier, we can all give the speech on the single payer, and you're giving it right now, but the details matter. So I am curious as to just really drilling down on, okay, great. You know, I hear all that. Was that argument enough to, you think, that would have moved your legislature to be able to get, you know, past the tax increases, et cetera? That
yeah, that's where I'm going. That's
okay,
where I'm going.
Sorry. Okay.
So we all know the facts. The answer is yes, as long as those increases weren't going to follow the pattern of healthcare premium increases. In other words, our legislature, I could have convinced our legislature, if we had cost under control, to move to a publicly financed system. I'm sure of that. Not if you took out the Obamacare challenges, the fact that I'd lost my credibility in many ways, and legitimately, for legitimate reasons. So, you know, I think my answer to your question is, as I said right from the beginning, if you're just worried about focusing on financing of this package, you're dead. You've got to find a way to move the California healthcare system, and this is a much tougher job, to one that spends less money for better outcomes, more in line with our wages. And the answer is, if you can do that, you can pass the financing plan, and legislators will happily continue with it because it'll be better than the system we have now. My challenge was I hadn't gotten there. And, you know, legislators, what legislator from any party is going to vote 20% increase next year on your payroll tax, because that's what the healthcare system is gobbling up, 15%, 10%. They're just not going to do it. And income tax, right? So you get what I'm saying. When I said to Mark yesterday is, if I could do it all over again, I would not have pulled the plug. I would have passed my plan with the Democratic legislature that I had. That I would have been called a compromising politician because it wouldn't have gone into effect until healthcare costs in Vermont mirrored 3%, 2%, 1% of GDP. You pick your number, you pick your math, it doesn't matter what you choose, but some reasonable compilation, that's when publicly financed would kick in, and this would be the system. And I think that you could pass in California. And frankly, I think it would push the feds to move as well.
I want to make sure.
But Richard, just want to be clear, you won't get there if you just do the financing in isolation. No rational legislator is going to move from a busted system that spends money like a bunch of drunken sailors at a rate that can't be sustained and say, hey, if we just move to a publicly financed system, it's going to solve all the problems. No one's that naive.
Thanks.
So I want to get to some of the other questions. Thank you. And I'm going to go to you first, Sandra, and then we'll go to Bob and then Rupa. But Sandra, also, I think part of what we are hearing, and I was thinking about this yesterday, Governor, and Sandra, I bet you have some thoughts on it. It's sort of a little bit the chicken egg question, like, can you fix the system before you move it? And do you, the condition of fixing it first and then moving, how does that line up? How realistic is that? But Sandra, if you have thoughts on that question, answer it. Otherwise, go with what you were going with.
Yeah, thank you, Mark. Thank you, Governor. Thank you for the effort, first of all, and for being with us today to share some of your observations. I wanted to pick up on something that you said that I thought was particularly important, a conversation that we've been having somewhat on the commission. And that was this notion of moving the delivery system from a fee-for-service system to an outcome-based system. We talk a lot about delivery system reform here. We have a very diverse population in the state. We have enormous inequities. And many parts of our delivery system really have not moved effectively yet to an outcome-based system of reimbursement for providers. So I wondered if you would just spend another minute or two on what that was like in your thinking and in your plan and how it played out for you as you move forward or tried to.
So I didn't seek a fourth term, and what I did was set up the infrastructure to make that happen, and then I left. The Republican governor who followed me continued that effort, and it's still ongoing. Now, the only thing I would say is I don't think that it's been continued with much vision. So the result is that I think they've lost some time. But the answer is, if you go, you should get probably Anya Rader, Dr. Rader, or one of the people from the Greenmount Healthcare Board to talk to you about their current effort to continue this work. And really, the vision is pretty simple, that you, through a provider network, including everybody, not just doctors and nurses, but you bring in the chiropractors, you bring in mental health, you bring in your school systems, you bring in your opioid center, treatment centers, you know, the entire healthcare network. You build a network, it's not managed care. They still have their own practices and all that, but they get a per capita payment as a collective group for taking care of a huge cluster of patients. You weight that system so that, and they've designed all this so that the high risk people, obviously you get a bigger reimbursement for per, then you do the low risk healthy young people, right? So that's all built into the system. You use computer modeling to measure the outcomes really carefully and accurately, because otherwise there's obviously an incentive to maybe of your higher risk people take less of them, or maybe they don't get as much treatment. You know, in other words, you really need to have good controls. They believe they do. And that results in a system where everybody collectively is working together to keep you healthy. Suddenly they care desperately, you know all this, but they care desperately about what you ate for breakfast, what your smokes. Are you depressed? How's your marriage or your relationship, whatever you're doing? You know, are you drinking too much? You know, how much pot are you smoking in Vermont? You know, we're legal here, California. You know, all those issues. You really suddenly care about the blood pressure, about the diet. They're showing up on your doorstep and knocking on the door to check your diabetes, when before they were kind of like, just hope in this system they keep coming through here and asking us for more help. So that's a gross generalization. I can get you in the weeds, Sandra, as deeply as you want to, but Vermont has done a huge amount of work on this. It has not yet shown the benefits that I'd hoped, but I believe it will if given a chance. And they're about to go for a 5-year re-up of the agreement that I got out of the feds. But the work, they've done a huge amount of work on this. And you know, governors, we talk in big pictures. And, you know, we're not very capable of getting in the weeds. I mean, I could with you, but you'd be much better off talking to the team who's actually making this happen. We've got the example in Vermont of how you'd set up the infrastructure to make this happen in California. But you got to do it. I mean, listen, what do I think in the long run? What was my hope? My hope was, and I want to go back to a question that Senator Pan asked, which was, you know, how do you play the players? I went to Blue Cross Blue Shield of Vermont because you mentioned government can't even get your vaccines out. They shouldn't. Don't try. You know, let the people who know how to do this stuff do this stuff. And I was honest. My single payer system, I was going to contract it out. I wasn't going to have a Vermont run insurance company. Can you imagine? I mean, that would be any governor's biggest nightmare. Who the hell wants to run an insurance company? I was going to contract it out to Blue Cross Blue Shield and steal their reserves while I was at it. Because when you get to reserves, you're going to realize you need those. And you don't want to raise taxes to pay for this system. And then say, and by the way, taxpayers, we've also got to do a little bump here to get to the reserves we need to have this single payer entity not go bankrupt if you get sick. So my point is, there's a lot in the weeds that matters. And I don't want to bore you with it now. But having said that, we've done a lot of this work, and you could do it even better in California because you're so big and mighty.
All right, 2 rapid fire questions, because we can go over a little bit and eat into our planned break, but the governor has a hard stop in 2 or 3 minutes, I believe. So
my chauffeur just came in the room and is
okay, we're gonna do the last 2 questions, and then Bill.
I used to be able to speed in Vermont because I had a lot of blue lights, but they took them away.
Yeah, well, we want you to be safe. So Bob, you go for it, and then Rupa, and then we'll let the governor go, and Bill, I'll have you wrap it up for us.
Yeah, again, thank you, Governor, for your participation. Really helpful insights here. I run one of the 3 foundations that are represented on the commission. My question to you is, what advice do you have on us if you were able to do a do-over on the aspect of civic engagement, community engagement, public support maybe even messaging and narrative, which at the end of the day is always something politically unpopular, is going to need a groundswell of grassroots support and activism. I was just wondering, any observations or thoughts you have?
Yeah, I mean, that's a great
Let's assume
question.
what we come up with is going to work.
Right. That's a great question, Bob. Listen, I ran on single payer. So, and I ran against an opponent who was absolutely against it. So in a way, I set up the grassroots infrastructure, or they came to me and we all worked together and we had an amazing infrastructure. Community-based, lots of conversations, lots of forums, lots of debates on this subject. I was criticized when I pulled the plug on single payer for not having continued and built that community organization to make it even stronger. Frankly, my own view about that is when I saw I had to use all my energy to build the exchange, to get the exchange fixed, to get Obamacare up and running, to take care of all kinds of other challenges that governors deal with. And by the time I was seeing the early numbers and the early plan and looking at the cost projections for Vermont for the next 3 years in healthcare, I knew that I wasn't going to be around long enough to, unless I could get this done, I would have tried to stay, but to build the coalition that we needed to pass it after me. In other words, I didn't try. And I didn't try because when I saw the challenges I was facing with the public on healthcare, knew there was no way I was going to be the guy at that point shattering my hopes to transform the first healthcare system significantly in America. I did not continue that coalition. I didn't put my energy there. So some have criticized me for that. Frankly, I had enough information at that point to know that my time was up. But the answer is, listen, there's big job, lots of big jobs here. But one of them is a governor, because it's got to be a governor. I don't think legislature can do it, that is leading the charge to explain to the people that have elected them why this is so important. Now, luckily you have a governor who's supportive and a damn good salesperson. You need it.
Thanks, Governor. And Bob, I think we'll get into this a little bit more because I think it's such a critical question, and California's diversity and just the fact that we're so big physically, I think, are going to require some other other thinking. Rupa, bring us home with the question. Thank you.
Thank you so much, Governor, for taking the time to share with us your insights and your experiences. I'm a hospital medicine physician at UCSF. I've been on the front line in the hospital at the bedside of COVID patients during this pandemic. And I've been very concerned about how California policy in dealing with the pandemic has been really impacted by the hospital executive lobbyists. So many of us were agitating to be tested weekly. The NFL was being tested twice a week. None of us got tested. We were being told to go to work when we were testing positive for COVID. We were told that elective surgery should continue. I personally got exposed by someone who came in for an elective surgery and had to go into quarantine. So, the stress of not wanting to infect our children, this was before the vaccine, this was in December when we were peaking with the cases here. It makes me very concerned about how lobbyists will be trying to shape this move. And while Blue Cross and Blue Shield did deliver vaccines, many municipalities hated the deal and went with their own thing anyway. So how can we, what is your advice on creating a bubble, a pillow around us to manage those kinds of pressures so that we can actually push forth for a system that is no longer extractive of the public good? And you mentioned climate change, which I think that this is exactly the same issue with climate change. We have these industries that are extracting from the public good. The healthcare industries, private, nonprofit, whatever, are still extracting those healthcare dollars that should be going to give our nurses PPE and to get us tested so that we didn't have to die. Healthcare workers did not have to die in California, and it happened. And it happened because private insurance and private industry was driving the policy. They were in the ears of the people making these decisions. So what is your advice there as we forge forward?
Well, Rupa, I think that was beautifully articulated, and I really don't think that it's the payment system that's the ogre in the experience that you had. I think it's the fee-for-service system. In other words, imagine that you were in a healthcare system where the hospital executives that were making those decisions had their pay based upon actually keeping you healthy, I think their reaction would have been very, very different. Currently, having you come in as a COVID patient, actually, I don't want to be too crude about this, but it's all billable stuff, right? It's all billable care. And, I don't want to suggest that that's what they wanted, because it's not, but perversely, our system collectively rewards patient care. It does not reward healthy outcomes. And I don't think these two issues can be divided. I really don't. I think if you and I understood that as a governor. Now, explaining that to the public, very, very tough, much harder than just talking about financing. But we do have a broken, not just payment system, we have a broken healthcare system. And you cannot fix one arm without fixing the other. And your experience is a beautiful example for Get Payment of how broken the system is. It really is. And we could all cite in our families millions of examples. I won't bore you, I wish I had time, but I've got one with my 90-year-old dad, where they just they do insane things that you would never do in a system that wasn't just billing every procedure. You would never do the stuff they did to him. And I know that you all on this panel can tell stories of your families and friends that have seen it. So listen, this is tough stuff. This is the stuff that kills politicians. Ask Bill Clinton, ask Hillary Clinton, ask Barack Obama, ask anybody that's really tried. But I'll tell you, why did we have President Trump? My view, because of this. He identified that people were pissed off, that they were making less than their parents, and their life was looking more bleak. What he misidentified was the cause. He blamed it on India, he blamed it on China, he blamed it on the Mexicans, he blamed it on religion, he blamed, religion, he divided everybody. If he had just said, listen, our GDP 10 years ago, 20 years ago, we paid 10% healthcare. Right now, we're about to hit 20 cents on every dollar. If we keep spending the way we are another decade, it's 30 cents. Do you want to know why you're not making as much money as your parents? That's why, my friend. So listen, I've run out of time. Rupa, your question is so deep that we could spend an hour on it, or two, or a day, or 6 months. I will help you in any way I can. I know I've probably put you to sleep, but listen, I've got the people that can do the groundwork, that can really, and I know Bill does too, that can really make you not have to reinvent the world again. California is a very different state than Vermont, but I hate to tell you, 90% of this, you're going to be trying to solve the same problems.
Governor, thank you for being direct and dealing with the questions as they came in. Really appreciate you. Drive safely. We'll be in touch as we need, not if, as we need another lifeline or a question answered. And really just grateful to the commissioners for engaging the way they did. Governor, thanks again, and good luck getting to where you have to get.
Good luck to all of you. This is the most important work, with the exception of climate change, which is related, that you could be doing. So thank you and good luck.
So for the commission, before we take a 5-minute break, Bill, I think it's you were there earlier then, right? You were there at the very early stages. You gave us a paper with 3 options. You kind of put out the option that made most sense. I think it's substrate made it into the final plan. What comments do you have? And especially in the 3 options that you laid out as a tee up to our next conversation, which is really about the attributes of the system. Not only do you pay fee for service or capitation, and what do we do about this or that, but you offered some different proposals in that paper. Just wanted to hear you briefly and just highlight a few things. And I promise we'll get a few-minute break, everyone, because I know you probably all had something planned for it. But Bill, take it away for a couple minutes and then we'll go to break.
Well, I just quickly summarize what Governor Shumlin said. He says often there's a political opportunity to make a major difference. And but then one key point he made is the governor or the state government must have the credibility that the people have the confidence the government can actually execute it. I thought that was a key point. The second point, of course, he emphasized time and time again, there are a lot of details, and the devils are in the details, and that you have to really look at those details, which can often trip you up. So those are the two major messages I thought he gave us, plus others. But then I just like to add one of my observation at that time. I was not actively involved. When we designed the plan for Vermont, I talked to unions, grassroots organizations, employers, chamber of commerce, providers, and so forth. And we designed a benefit package that will cover 87% actuarial value, so-called, because from consulting the people who had to pay, those are the employers, as well as some of the workers, they say that's all they're willing to pay if this is financed from payroll tax and income tax. But once we submitted our report and Vermont passed the first legislation, in between, as the Governor Shumlin said, there were several years lapse. People with a noble vision say, we want much more comprehensive coverage. They more than increased the benefit package by 10, 12%, cover close to 98% of the actuarial value. That actually lost the balance between who have to pay and who is going to benefit. I always call this is a tragedy that the perfect became the enemy of the good. That's one message I like to leave. I learned from Vermont.
All right, Bill, thank you. So are people okay? Let's take five minutes and come back. I don't want to lose too much time because I think the next set of conversations is also important. So let's say 2:17, 18, get back here. All right. Thank you, everyone. See you in a few minutes.
Commissioners will be reconvening. If you can hear my voice, we are coming back online.
I'm going to give one more minute. Get everyone back. Thanks, Karen, for helping me. Bill and Andy, if you decide to start having dinner, don't worry about it. Thank you for doing this so late.
Thank you, Mark.
All right. Karen, what do you think? Get started?
I suppose
Yeah.
we must, yes.
Okay. All right. So as I teed up, just to give you the rest of the lay of the land, we're going till 4:30. This conversation we're about to begin, wrap up right before 4. If we go right up until 4, I'll do that. I'll try to summarize right before we go into public comment. And I'm sure a whole lot of good questions from the public on both what we just discussed and what we're going to discuss. So in our last meeting, we talked a bit about potential ways to structure the unified financing system of the future of California. I asked the question, what does it look like if this is what we committed to doing? Appreciated Richard Scheffler's sort of bringing that home and asking some other really important questions. I think Bill at some point will follow up with you on some of those questions that were asked at the end of your presentation. But I think terrific start to a series of conversations today. I wanted to dig in a little bit more on what the new systems design would look like as it relates to 4 things that we've talked a lot about, which is accessibility, quality, equity, and affordability. And to do that, I just want to reiterate that kind of as we have evolved these conversations, and I just want to give a particular thank you to Anthony for what he did a couple weeks ago when I asked him, hey, I want to tee you up to be part of this. And he challenged me right back and said, you know, let's not have a conversation that it's this versus that. Let's instead talk about how California thinks about transitions from where we are today, or what do the, my words now, but your thoughts, Anthony, some of it, what do the attributes of our system have to look like for us to build towards something different? And I ask us to think about the attributes, not as they're applied today in a fragmented system where you have a lot of different players, you have risk pools that are separate, and people compete for quote, better risk pools based on whatever they do to get there. We want to talk about a system that's unified in its financing and unified in its risk and who's involved. So when we're thinking today about attributes, even if you hear an attribute that you've thought about, well, that doesn't work today, let's have a chance at a conversation about what it looks like to potentially have a chance in a different kind of environment. And so each of the panelists that we're going to pull in today in the order of Peter, Sandra, Anthony, are going to talk about this from that viewpoint, using their experience, their expertise, their knowledge of what it's like today, but to really dig in a little bit on how we think about that work in a very different system. So this isn't a this versus that conversation. This isn't a, well, it didn't work over here, so how could it ever work over there conversation? Although there's things, the attributes of today's system that we may decide, you know what, even in the best situation in a unified setting, that isn't going to work. And I want to hear those thoughts and reasons behind. After we have the panel, I'll pull a bunch of you in like I have already, asking you pretty clear questions that I think draw on your expertise, but also some of the opinions that I've gathered you all have sort of shared with the commission broadly. hopefully never to make anyone uncomfortable or put them too much on the spot, but to get us going and not to avoid the elephants that are definitely in the room on some of these issues. So with that tee up, Peter, I asked you to talk a little bit about not just your experience at Covered California and the exciting work that you've done there over time to work within the confines, the structures that we have to do well on some of the attributes, I think, or the values in the system that we think about or want to see, but also to talk about some of the challenges that being in charge of a system with 2 million out of 40 million lives causes, right? And what you think is in your broader career, not just Covered California. I know that that's where you spent a lot of time, but you have such a rich resume of experiences in the space, both federal and locally. Kind of what do you see as opportunities to build on? And where are new pieces that you might want to invoke and say, hey, we really need to build this in our pursuit of those things? So 5 to 7 minutes, take it away, and then I'll tee Sandra up next.
Great, well, thanks. And it was really great hearing from Dr. Someone and both his struggles and some of the things that he's done. What I'll try to set up is to reinforce some of these attributes that we are working to do now, and where we have some evidence and are missing evidence, and where we need to go. And so I agree with your framing, largely, Mark, about the sort of what we often call the quadruple aim of better health care, lower cost, I add quadruple, better experience of clinicians. But two elements that we often get confused in talking about as lower cost isn't necessarily affordability. And I want to start there. So that's one. And before going through those attributes of affordability and where consumer fits, I want to remind us, it's not about financing in the end, it's about these ends. And our current system has 4 major different systems. We've got Medi-Cal, which is functioning really well in California. We have employer subsidized insurance, which has about 50% of the people in it. We got Medicare, and then we got Marketplace, like Covered California, which sort of bridges the gaps. Each one has different ways it's tried to address these attributes of the quadruple aim. And what we all know is we have mammoth fragmentation, misalignment of incentives, et cetera. So let me walk through each of these very quickly in the domains of attributes. First, affordability is good news. We're at 93% coverage in California. Okay. Good news, Medi-Cal has really good coverage in terms of protecting consumers so they don't have financial impediments to needing care and not having to go bankrupt, which are some of the goals. Good news, Covered California with the new subsidies means that lower income people pay none of their income and get really rich benefits, sort of like Dr. Shao's 98% benefits, that 98% AV, actually 94% AV. Bad news though, both ESI and Medicare is a really mixed bag. And I just want to note that we've got a gap not only of 7% uninsured, most of whom are undocs, but big population of underinsured and employer-sponsored coverage, meaning that they're spending a high percentage of their income on coverage, and the coverage is mixed. Medicare also a mixed bag. We got a lot of people in Medicare, seniors, paying a substantial portion of their income towards healthcare. So I think this cues us up to think about, it's not just how much you pay, but what Dr. Shao queued up, how much do you pay for? Is it 85% AV? Is it 95? But in particular, one of the things I think we've moved to doing right is income adjusting what people pay. The system doesn't do that. Medi-Cal does, Covered California does, but ESI doesn't, and largely Medicare doesn't. So that's affordability, progress where we're going. Next, and I'm not going to talk so much about consumer choice. I want to talk about health and health care, because this is the biggest casualty of a fragmented system. It's not just about health plans, which are now required to not avoid risk. They're now required to spend money on healthcare. No one owns a person for the lifetime. No one's responsible for health of a population. So we have a fragmented system that thinks short term. And we have a system where you're likely to get in the right care at the right time as a coin toss. I really appreciate the governor saying if we don't address not just cost, but quality, we got a problem. And this is a note on evidence. The evidence is a lot of indicators that care is better if it's integrated and coordinated. Evidence is pretty clear that if it's fee-for-service, disintegrated, fragmented care, you get more and not better. That said, even within organized care, which we do, Cover California, selectively contract with health plans. They can't make more than a certain profit, all those things. But even within that, we got big variation, even within capitated systems. Kaiser, capitated, does a really good job on quality. They organize it, they track it, they meld it together. Other carriers don't do so good. So what does that mean for us? Boy, two things. One, you got to have someone looking over the shoulder of the plans and what they're doing. And a little group like Cover California with our 2 million lives has to be working in alignment with Medi-Cal, PERS, other purchasers. If you don't have an all-in system, you've got to have alignment on measures, what you're holding plans and providers to account for, how you're promoting primary care, how you're exchanging data, how you're addressing disparities. These are all sort of essential elements that, absent a unified system, you need to have alignment, which we right now don't have. The last element, and I'm being mindful of time, is I talked about affordability first, and I really see affordability as separate from cost. Cost is a system attribute, which is how much are we spending? Is it 18% or is it 19%? And look, and I think we all know this, but I want to remind us, there's 3 reasons the overall costs are bigger in America. Number 1 is admin. We spend more on doing administrative crud. Number 2 is pharma. We spend a lot more on drugs. And number 3, which is actually the biggest, is we pay everyone more. And I want to be really clear. This is back to the winners and losers that Anthony and Dr. Sumlin talked about. Dr. Sumlin said it's the specialists. Well, why? Specialists get paid a lot of money. But, and I know I love primary care, and primary care docs in America get paid twice what they make in Europe. And our nurses, God bless them, doing great work, and they're well paid compared to other nations. So when we think about that, boy, do we need to think about big levers, because the levers that a Cover California has, too small. The levers we have to address underlying costs of absolutely get folks out of fee-for-service and into pay-for-value, get into systems of care, will be on the margins. The issues that I really appreciated the governor's note is if you don't get our arms around the underlying costs, it's hard to do the rest. And those are issues. And I know, Mark, the legislature, governor's looking at the Office of Affordability, but the big solutions down the road for costs are about global budgeting, common pricing, and these are big political challenges. But without addressing those, we don't have the solutions to get to human affordability and promoting the system that we need. So that's my 7-ish minute kickoff on some of the issues for attributes and what the challenges are.
So before we go to Sandra, Chair Prerogative, ask you one question, Peter. The work that you all are doing on equity and quality,
yep,
and that transformational work, you're building upon a chassis of essentially capitation and working with plans to try to influence their focus on those issues. How, sort of what's the, in a minute or two, what do you see the odds of, where do you see the tripwires and the challenge, and what are you most hopeful about in that, given the experiences you've had?
Well, a couple of tripwires. First is, it's not just building on capitation, what I think is right, but it's building on systemness. It is trying to get out of delivering for doing more and rewarding more, and we're actually pushing systems to take care of a population over time. It's the over time element which is vital. And to my mind, the big tripwire that I see for the whole unified financing and payment system is some of those discussions are about, oh, let's have it be all about every provider, fee for service, get rid of quote unquote intermediaries. The organization of care takes work. And I think the main thing is where we see where it's less done, you aren't addressing disparities effectively, you aren't addressing qualities effectively. And it doesn't need to be at a health plan level. It could be at, we actually have about 25% of our non-Kaiser enrollees in accountable care organizations, which are organized, cutting across, and the better ones are organized by primary care providers that are organizing care, supporting teams of clinicians to deliver care over time. And I think that's the key attribute that we need to be developing, whichever the system is of payment. Got it. That's helpful.
Don, I'm going to hold questions till we're all the way through, if that's all right.
Good try, Don.
Yeah, good try. All right, Sandra. Thank you, Peter. Sandra, I asked you specifically to think about how a potential unified system and how we set it up, both with this attribute of the financing and all in. What is it that we might hope for, expect, be concerned around, especially around two populations? I've spent a lot of my career and chops on, this current budget around behavioral health, right? And we know that our healthcare delivery system, physical healthcare delivery system, has not always done an optimal job recognizing, pulling in, and frankly, that's a compliment to where we are on that integration. And then second group of people are those with chronic conditions. I mean, we know that, Peter talks about the primary care role. We know that I often joke and say pediatrics is the ultimate form in adult preventative medicine, not joke. Richard, I think that it really is the earliest opportunities to turn the tide on chronic disease, but we need a system that does well on chronic disease. So with those two things specifically in mind, I'll turn it over to you to make some comments.
Thank you, Mark. In 5 minutes or less, how to cover our behavioral health system, what we've learned about it, what works, what doesn't. If I can get to chronic diseases, I will. But there are certainly themes from this afternoon's conversation that I want to come back to. And really, I want to pick up on something that Peter said, because in the behavioral health system, and let's be clear, we're talking both mental health and substance use disorder. Keep in mind that this is a population that has a disproportionate disease burden. If you look at cost of care, if you look at morbidity, if you look at mortality rates, people who have any one of these serious mental illness and or substance use disorders, regardless of what system they're in, succumb to largely physical health related diseases. At the same time that we are spending a disproportionate amount on this high need, high cost population, we actually get very poor outcomes. In general, that's the state of the system we have today. What we know works, because you asked me to talk about attributes, Mark, I would say that for this population in particular, care coordination, care integration is absolutely critical. And today, because we have such a tremendously diverse sources of funding that come to the delivery system, forget plans for a moment, that just come to the delivery system. You have delivery systems that are looking up and reporting process measures, but tens and 20 and 30 and 40 different measures. We have not even agreed as a delivery system to articulate what is important to measure and to make our goals as it relates to outcomes. So we report how many people show up for a visit, but we don't actually today report, for example, how functional is that individual? How able are they to go and get a job? How able are they to maintain family relationships and therefore be regularly housed and stably housed in many circumstances? So the behavioral health system that we have today is deeply fragmented as it relates to financing. has not agreed upon quality measures by and large. There are a few that we measure, mostly related to hospitalization. If you got admitted for a psychiatric admission, did you get to a psychiatrist after that, or did you get to an appointment after that? But not really overall population-based, not over time, and not really looking at it from the patient's full self. We don't have integrated information systems and data systems. So what I would say today, we know a lot in demonstration programs, largely that are funded by the federal government, but not exclusively, but often in demonstration programs. We've got 250,000 people in California in whole person care. That's county by county, picking off different populations. The theme that runs through all of those in terms of attributes for success is care integration and care coordination. So then the question becomes, well, who does that? And who is best to do that? And how do we make sure that our information systems allow that to be as seamless as possible? Right now, our information systems are rudimentary at best in the area of behavioral health, rudimentary at best. So I would argue that as we think about attributes that work, you have to answer the question, where does the care integration happen? Where does the care coordination happen? How does that accountability have any transparency? So how can the public look at it and say, this is what works and this is what doesn't on any particular intervention or outcome measure that we agree to? And I say all this lovingly. I ran Department of Public Health. I ran behavioral health. These programs are wildly fragmented. And today we put the biggest burden on our most disenfranchised populations to try to figure out their maze through our behavioral health programs. Let's not even really refer to it as systems. So we need better data, we need better measures, we need full integration. And yes, would having less funding streams come in help? Probably. But that won't be sufficient to make the kinds of investments that we need to make. Access in behavioral health, we already know that. That's atrocious. We've pulled that all through the state. If you look at national numbers, not much better. It's in the low teens of people who need substance use treatment who can get into treatment. And a minority of people with mental illness get access to mental health services at all. So we have, in addition to things I mentioned, workforce issues, which you're deeply aware of, Mark, and I know the governor's done a lot in this space, but is a psychiatrist a specialist? Is a psychiatrist a primary care physician? Depends on how you look at that, but that's a good model for sort of thinking about how and when do you get access to what kind of support you need, and whether it's specialty or not in behavioral health or in another chronic disease. So because right now we have so many different financing streams, there is no single point of accountability. And it's incredibly difficult to say, what are the outcomes for this population that we all want to move towards? Because when you've got so many different funding streams, federal, state, local, hyperlocal, grants, all of those require their own version of reporting. And so we end up with a population that's wildly underserved, very severe inequities. Everything I mentioned is exacerbated significantly if you look at it from an equity lens. And so I would argue that if we were going to start somewhere to ask ourselves, where can we improve access? And in the case of behavioral health, that also means reducing stigma. That would help enormously if everybody was in an integrated, coordinated system. So we've got pilots of this, but certainly the financing makes it more complex. But we have many, many more challenges in the behavioral health space that we should think about. You know, the governor talked about what are the things that were done before they moved to unified financing. And this area of behavioral health, I would argue, is the least functioning part of our delivery system, bar none. So wasn't terribly upbeat, Mark, but I hope I touched on the things you were hoping to get to.
Yes, Andrew, I deliberately gave you the less upbeat topic.
Yeah.
Just kidding. Thank you so much. I think reality is better than fabricated upbeat. So thank you for that, as always. Anthony, I think you've distinguished yourself as somebody who thinks about the consumers, thinks about those who live and experience the decisions that Sacramento and Washington make. And you, I think, have a great sense of what has and hasn't worked with our current systems and what in a future system, unified system that I think not just is unifying financing, but unifying risk, hopefully unifying responsibility, what these systems might aspire to around accountability, and what are the attributes of us being accountable as a system in making sure that consumers are well looked after from you and your organization's perspective. So I'd love to hear some of your thoughts on this issue. And then Don, I didn't forget the raised hand. I'll come back to you quickly.
So thank you, Dr. Galley, and I I appreciate and support a lot of what Peter and Sandra just said, and so we'll try not to repeat. You know, as an organization that strongly supports a single payer and unified financing system, that usually is shorthand for a bunch of things beyond just the financing, right? I mean, there's an assumption of universality. There's an assumption of some mechanisms of cost control. But I do think it's helpful to sort of distinguish what is inherent in a unified finance system and what does such a system provide the levers or the tools for additional changes to improve quality, to control costs, to reduce disparities, to promote public health, tools that we don't have or that we're much less able to do in the current fragmented system. So, there's the stuff that's inherent in the unified financing, and then there's the stuff that we frankly really need to make sure is designed with the right incentives in mind, that is developed within the system and from the get-go. And these are incentives and structures both for patients and for providers. So, for example, I want to, just to put a straw man argument out there, I would have questions about a single payer system where everybody would be given a card and theoretical access to any provider at any time, but without any guidance or direction about what providers were available, which ones provided better quality, which ones were more culturally competent, which ones were more appropriate to a certain medical condition or circumstance, much less everything else. We wouldn't, even in a vastly simpler system, we wouldn't want patients, and especially those who are in definition in their most vulnerable medical moment, to just to be all alone. We're going to need navigation. We're going to need assistance. Even in a world where we have no or minimal cost sharing, we can't let the default be let the buyer beware. And I think we've, while consumers want choices and maybe more choices, they don't want bad choices. And I think that's driven some of our consumer advocacy as well. We have, been part of, I think, a broad conversation to the health plan about how do we move toward having more and more people in a medical home where they feel a sense of belonging. We've done some work, even for people outside of a context of a health plan for the remaining uninsured, including the undocumented. We've worked in county by county to make sure that there are these medical home programs that provide that sense of belonging, that sense of ability to start to coordinate care that might be needed between specialists, especially with comorbidities. And that's where the health system has been going, and I think with some results to prove it. And I think, Professor Howe's paper, has a whole section about the benefits of accountable care organization, ACOs, in the context of a single payer system. I think a lot of California is in delegated model medical groups. Dr. Ross highlighted the model of the community health centers, which is so vital for such an important part of our population. So how do we make sure that, how do we preserve the best of the models that we do have in providing that, in providing that care? And what do we want to encourage? What do we want to mandate? Or, and in what circumstances can people, if people do go into a specific system, what are the ability for folks to move, et cetera? Because we would want to think that, if we are going to a world where, not that people are choosing health plans, I do think that my hope is that the single payer system that we're creating, unified financing system, is basically taking most of the functions of health plans, whether it's aggregating risk or negotiating with providers or the like. But I do think that maybe there is a possibility of folks choosing between systems or choosing between different systems, whether they be integrated or otherwise. And then the question is, how do we make sure that there is accountability for those systems? How do we make sure that there is control? So for example, right now, theoretically, health plans use networks, preferred networks, formularies, and other tools to steer patients to providers of greater value and quality. If a new single payer system does not use these tools, then what would the alternative mechanisms be to ensure that kind of accountability and transparency? If a system or a provider does not, falls below a certain quality standard, how does the system respond without disrupting care? What happens if that's the main provider in a certain area? If the unified finance system does use those tools, some of those tools like networks or formularies, then it needs to come with the protections and oversight that we have developed over decades now. We have right now requirements that people should, if people are agreeing to a certain network, they should be required to, they have a right to timely access to care within a certain standard. And if not, they can go outside of that network to get the care that they need. People have a right now to get a second opinion if they are not able to get the opinion they need, an independent medical review. And right now, all of those consumer protection structures are basically done as oversight over health plans. And so if we're seeing a world without without health plans per se, how do we transfer those protections into a new system? And, I think that there is, we need to have clear standards and safeguards and rights. I think that's part of us building trust with the California public and frankly electorate, that they have some of these rights and protections, and this will be built into the system because that will be some of the questions they have. And we want to make sure that there is a responsive place for them to turn to results. And I don't know if it's an ombudsman or oversight agency. We can look to other models of how maybe one part of government keeps another part of government accountable, in the absence of sort of a traditional regulatory system. But we do need that kind of structure. And frankly, we need that regulatory and oversight structure to be proactive, not just one that is complaint driven. So we need a place for people to turn to, but we also need that. And then finally, on just the provider side, if the providers are showing themselves to be particularly effective at, say, managing diabetes or chronic conditions, the stuff that Sandra did not get to, how are they rewarded? How do they grow? Do they get more pay? Do they get more bodies? And then what are the mechanisms to do that? So I just want to finally just promote this notion of a medical home, that we want people to have a sense of belonging. We want people to have navigation. We don't want people to feel like they're as much as people don't feel particularly empowered by today's very fragmented system, we want people to feel empowered and assisted. I know personally when, helping my mom, an Ecuadorian immigrant who is totally fluent and totally been here for years, get lost in the system, I would say we would want that for everybody. And then the final piece is we do want the incentives to be also about that in any, if we are doing it through systems, we still want the overall unified system to be focused on population health approach. You know, we're trying to, I think we'd rather be, rather than per patient or per procedure, we'd rather have per population of a focus on how do we actually get healthy outcomes overall, and if there is and how do we do this even if we have multiple systems in an area? How do we make sure that all those systems are geared toward looking at root causes, upstream public health interventions that can save the system money and everybody else heartache? Thanks.
Thank you, Anthony, and all three of our commissioner panelists. We'll keep fiddling with this model, but thanks for being the guinea pigs. I think it was terrific. I'll just highlight a couple of things that I certainly heard because I want to get into these tools, dials, if you will, that we can use. I wrote down a bunch that I heard come up time and time again. I think the model of care, we heard about the medical home model. How do we advance the models that work in whatever financing and payment systems that we agree makes sense in our overall system? What about coordination? What about integration? How do we make sure that those two pieces of two attributes are upheld and used effectively? Sandra, you mentioned the woeful information sharing in behavioral health. I think we still see it in disintegrated systems and where those deliveries for patients are fragmented. Measures and measurement, I think core measures, getting some agreement, and then the consequences that go with those measures. I think you each talked a little bit about, well, what happens when somebody doesn't sort of deliver. Choice and networks. Anthony, you talked about networks as a primary tool and develop the system that we use to pay for care in a unified approach is going to drive the dominance and the presence of networks or not. And then incentives, I think that's wrapped into this a little bit, but how do you use at all, if at all, incentives to move the needle on some of these things? So as you all think about your comments, would love to hear how we dial these up and down a bit in that system of the future that allows us to use them effectively to deliver on the core outcomes. I think, Peter, you said it. What we care about is delivering on those things, not on a system for some financial reason or some other more esoteric reason. So with that, I'm gonna go to you first, Don, and a question for you as well. As you ask your question, just to think about, I'm wondering with, in your prior life, your prior job, you looked at a lot of health systems, not just here in the States, but internationally, like Bill, I think a lot of expertise. Where have you seen the sort of systems drive the use of these tools effectively? And what are some of those attributes that you would say, hey, that's something to learn from, and we should dig in a bit more down the road? And then, of course, feel free to jump in with the question you had your hand up for earlier with Peter. And then Carmen, I'm going to go to you next.
Thanks. So I actually didn't have a question. It was more of an add-on. This is a great conversation question about how we take these systems that aren't really systems that have emerged, that aren't anything like the systems or not very close to the systems that we would want, and turn them into those systems. But there's a related but very different problem that I think is really critical to flagging in California, and that's that in large swaths of the state, there are no systems. So, when you get north of Sacramento, you start to fall into areas where we have a very hard time at CalPERS cobbling together an HMO network. You know, we don't offer HMOs in a number of counties in the north, and the reason is that there isn't a system there to put together some sort of integrated network. So, you know, there's some innovative work that's going on to do that in more rural areas. It's not just rural areas, but it's primarily rural areas. But that's just something that we're going to need to think about as we think about how to have a unified system, is what is required to build the infrastructure in places where that just doesn't exist. And, you know, it's Northern California, it's Eastern California, it's chunks of the coast. So it's not just, you know, it's not just a few counties high north. It's, you know, we're a funky state in that way. And I think it's important that we put that question to the front of the line, or up there anyway. So that's just an observation. You know, as to this question of other systems, you know, the knock on the American system is that it's not a system. And one of the differences between that and a lot of the systems, certainly that we looked at the Commonwealth Fund when I was there, is that those were systems that were built as systems. So, you know, most of the ones that we looked at, all of the ones that we looked at outperform on a bunch of different measures. They have very different attributes in some ways. In some ways, they have a commonality, as I said, that they're more of a system. So, you know, we did a review of wealthy country health systems at the Commonwealth Fund on a regular basis. The NHS was frequently at the top of the list, single payer system. The Dutch system also often topped the list. It is an insurance-based system, but it is a heavily regulated insurance-based system. So the insurers operate with strict government oversight. They are not for profit. They look very different than the insurers that you see in the United States. As a practical matter, when you look at outcomes, very similar. You have more divergence if you look at like a Swiss model, for example, which allows for more sort of traditionally, from an American perspective, insurance-like activities, so supplemental policies and so forth. Those exist. But again, the chassis is a core system with a core set of benefits that are guaranteed to everyone where everybody participates. And at the end of the day, in my view, that's really the critical piece, that you're providing care for everybody, that you're operating as a single system. But there are, you know, I think the takeaway from looking at different comparative systems is there are a lot of different ways of getting there.
Okay, thanks, Don. Carmen, you have in prior meetings when it talked about or advocated for direct payments as opposed to using payments that go through something in the middle like a plan, and that the system that you imagine is one where the unified financing from the government entity is going directly to providers. In that system, how do you imagine, or can you see the accountability that we're striving for achieved, especially around equity and some of the disparities that we've sort of tackled and talked about in prior meetings?
Yeah, you know, I think before answering the details of the question, I think it's a good organizing principle when we're thinking of these issues to really understand, you know, that part of the problem, as you know, Peter mentioned, I think Sandra mentioned this also, is that, you know, the problem is the prices and the administrative costs. So fundamentally, when we're building these complexities through competing plans, competing networks, we're giving that money over for health industry profits, for administrative costs. We can't do that if we don't have a unified system, a single payer system that can have those savings from price negotiations, from administrative savings that are currently being used to manage the fragmentation. So, you know, I think that's a key question there, because, you know, as Don was pointing out, like, how are we going to fund all these gaps in healthcare? And I think that's one of the fundamental things about a direct payment system, is that when you're simplifying the system, we have savings that we can target towards the gaps, target towards the health inequities. So, you know, I think that's important to keep in mind when we're talking about different ways to reach quality and equity in a unified financing system. And really, you know, our goal here should be trying to design a system where medical professionals can do their job without influence from, you know, middlemen and managers, whether or not, or financial incentives, business incentives, so they can do that without having the burden of managing, you know, whether or not their decisions on an individual patient's care is going to impact their pocketbooks. Because fundamentally, some of these other models, the managed care models, to me, that's what they're doing. It's a backward solution, because we're placing financial risk on providers in order to economically motivate them to control costs, which, you know, ultimately means limiting care, denying care, delaying care. And I think that fundamentally, you know, it's going to be easier at the end of the day to monitor and address these issues and gaps in our system, or potential high use of individual patients, and to correct for those, rather than using third-party gatekeepers to deny or delay or limit care. So I think we shouldn't put this burden on patients to be able to identify when a provider is limiting care or denying care, because that's what we have right now in our managed care system. And I think it's completely inappropriate. And I think, you know, we have lots of examples right now where managed care plans have been, you know, using the system to deny care. You know, DMHC had a huge enforcement claim against 12 plans a number of years ago for denying care and then covering it up. So I think we have to remember that when we're talking about you know, the different models that are out there. And similarly, and I'm going to answer your question, but similarly, you know, I think we also don't want to hyper focus on outcome metrics tied to payment systems, because in the same vein, you know, we should question financially motivating providers to change their behaviors based on outcome metrics. You know, metrics, again, create administrative complexity, and it incentivizes gaming and teaching to the test by providers, rather than focusing on the needs of an individual payment. You know, and with the combination of risk-based payments and metrics, we're dialing the financial interests of providers up to 1,000. And, you know, we know that it causes proliferation of algorithms to game metric systems. And ARC is questioning right now whether or not these algorithms can exacerbate bias, particularly racial bias in our system. So we also have to fundamentally question, you know, what are we doing when we're saying that we're looking for outcome metrics? Like, do we really want to tie them to payments? And I think not, you know, because we don't want to incentivize this you know, corporate consolidation so that they can game the payment system. Okay, so, but to get to the question, so what can we do under a direct payment system? So fundamentally, we can build mechanisms in the funding structure to identify the health inequities within our systems. We can use some of the things that we use now. You know, to answer Anthony's question, we can use the DMHC to monitor for gaps. You know, instead of managing and getting complaints from, you know, how many plans, they'd be monitoring one plan. And they could take independent medical reviews. They can look and and gather all this information. And I think with a direct payments model, we're having a unified claims processing system so we can identify where the gaps exist. And, you know, with care under a single roof, you know, we can both identify the gaps and then target our funding in ways to our hospitals and other healthcare providers to meet those specific needs of different patient populations that are being served by different institutions. You know, one way to do this is through the way we pay hospitals and institutions. We can use institutional global budgeting so we can make sure that providers are being paid closer to actual costs, and that we can look at the populations that are served by each hospital to make sure that the needs are met, and that each hospital has, you know, enough money to have enough staff, to, you know, have enough money to extend operating hours perhaps, or if they need hospital construction, that can be paid through a capital budgets project, capital funding, or to renovate the hospital that if it needs additional funding to renovate, or we can use it to increase the number of doctors or nurses or other healthcare staff, particularly in rural or underserved areas where there's medical professional shortage areas. And we can drill down on why certain quality metrics aren't being met, and we can proactively address those for individuals. We can ask the question, why are there early discharges? Why are there high rates of hospital-acquired infections? Is it because there's improper PPE in the hospital? Is it because, you know, there is an underlying issue and perhaps an environmental issue for people within a particular hospital where they need to be readmitted because there's an underlying condition that's not being met for a particular set of people? And I think, you know, in a monitored fee-for-service system or a monitored institutional global budgeting system, we can have these kind of mechanisms to identify the gaps, and we can use things and pay for things like consultations with patients, consultations between providers. We can pay for, you know, in-person handoffs between patients to get to integrated care without incentivizing, you know, without using payment incentives to get to integration. You know, we can do that in ways where we don't have this problem of financial incentives of providers. Like, we can pay doctors for the time that they spend on coordination and consultation with a patient or with other providers. You know, if you pick up the phone and you need to talk to somebody specialist, we can pay you for that time, because that isn't necessarily happening today. And I think that's one of the big problems of trying to get people to providers to talk to each other and get to integration. And, you know, I think, you know, a single payer system can analyze utilization patterns. We can monitor and perform audits and intervene when appropriate. We can identify outlier doctors who perhaps are providing more, you know, overutilizing, and then trying to use, you know, in terms of quality, you know, we can have penalties if necessary if there are outliers. And I think, you know, in a single payer system, we can simplify the process, sanction folks if necessary, and we can use existing systems that we have to monitor the care that's being provided. And I think, you know, we don't necessarily have to recreate the wheel on a lot of these things. It's that we have to think about how do we pull out the financial motivations of the provider so that they can provide care. You know, I think it's false to think that everybody is operating under economic motivations. You know, I've said this to a lot of people before, like, I want a doctor that provides me care. I don't want a doctor that's, you know, the perfect economic rational actor. That's not what my doctor should do. My doctor should figure out what I need as an individual and an individual patient. And it's particularly disturbing to me if we're trying to use these kind of economic pushes and pulls to change doctors' behavior. And to me, it's fundamentally a question of medical ethics. We don't want doctors doing that. And I think it's wrong to try to make that happen. And, I'll leave it there. I have a lot of other things I probably could say, but,
Thank you. Yeah. No, and I appreciate it. And the balance of how do you use some of the existing tools, but unravel them from some of the economic focus drivers, I think is one of the big challenges of healthcare. And I want to turn, I see a bunch of hands up. Some hands came up and down. Richard, Senator Pan, I wanted to come to you. You had your hand up, it came down. I'm gonna come to you with a specific question, building a little bit on what Carmen's talked a bit about. We have a bunch of tools. I mentioned some of them, many others that we've used for accountability. What do you think are those tools that might make the most sense that we haven't touched on already, or that you've seen or studied in systems that help us achieve the accountability we're looking for? Mindful of Carmen's comments that some that seem purely to use the financial motivations aren't always as smooth sailing and usable as we want to believe at the front end.
Well, actually, my question had more to do with behavioral health, because I wanted to comment on Sandra's presentation. I really do.
So you can do both. I hope I can draw you in on my question and then have you make your comment.
So first of all, I'm going to say is that I'm going to start on the baseline, say that I went into medicine. I know the physicians here went into medicine. We want to take good care of patients, right? We do have to make a living. We have families and so forth, but we're not like looking to maximize profits. I will point out that I chose to be a pediatrician who takes care of underserved families who mainly take care of Medi-Cal, and frankly, as honors society in my class, I could have certainly picked the specialty and made a lot more money. I see a lot of colleagues that are the same. And frankly, I've been in the and I think it's important that we allow healthcare professionals to put patients first. I even know that in the policy world, there are people who've criticized that actually they think health professionals should think about other things first and not patients first. And I've always said we should think about patients first. That being said, I also, I'm not naive to human behavior and also systems issues. So even when you're trying to do the best for patients, you have to deal with systems issues. So for example, let me just give you an example from research that I personally now I'm just involved and directed. Deciding whether to prescribe a medication or not to a patient, right? What goes into that decision making? Well, certainly part of that decision making is whether we think it's appropriate, it's going to benefit the patient, so forth. But also, frankly, we also are people and we interact with patients. They're human, we're human. And patients or their families will often ask for medication that may not necessarily be appropriate for the patient. And so what do you do in that circumstance, right? You have a relationship with the patient. You hope the patient trusts you enough, or their family trusts you enough when you say, sorry, I'm not going to prescribe that to you, that they'll be okay with it. But we also know that's not necessarily true either. People have different expectations. Actually, interesting enough, we just talked about this last week with Dr. Xiao, and I do appreciate he sent me an email. I agree with him that there's a culture in Taiwan that pre-existed their single payer system, which actually emphasizes prescriptions. But you have people who come from that culture, right? And so the question is, what do? Do you prescribe? Which, by the way, if I prescribe or not, it doesn't change my personal compensation. So it's not going to be driven financially by me, but there's a cost to the system if I prescribe and they fill it and it's not really something they really need, right? And so that comes down to the question is, what is waste, right? Is that waste or not? Well, maybe it'll help me maintain a doctor-patient relationship that may help later on. Does that, build trust with the system so that I can persuade them for other things that are more cost-effective? Or is that just purely waste? Because after all, the data shows that that's not necessarily the right thing for the patient, right? And so how do you deal with that kind of issue, right? And then what happens when that interaction gets multiplied by all the millions and millions and millions of doctor-patient interactions that happen every day, times a year, times all the cost of that, right? So I do think that we do have, it's not so easy to say that, well, we have 20-30% waste in the healthcare system and we just have to find it and cut it out. Because what is waste, right? Is it waste to have extra nurses sitting around in a hospital when you actually need them when you have a crisis? But they're not doing, but they have a little less to do when things are quiet. Is that waste or not? Surge capacity, is that waste? Is it waste to have delivery room nurses sitting around waiting for someone to come in a rural hospital because their volume of deliveries is fairly infrequent, but yet that would mean if you closed it down, the next OR, the next OB delivery site is going to be another 100 miles away, but yet the volume is so low that most of the staff is sitting around, like let's say 25% of the time, not doing anything. Is that waste or not? So, I think, and so what do we do with the system, and is it, how do you make those kind of decisions and so forth, I think becomes very important. Now, right now we make it economically, but then if we do move to talk about levers, right, we go to this single financing system, do we make those decisions politically, right? Do we make those decisions politically? It's been, and I appreciate, we heard from the governor, from New Hampshire, about, people talk about, oh, it's the lobbyists and et cetera. But, let's see, Anthony, Health Access is a lobbying group, right? We have labor here, the lobbying groups, they whisper in our ears, but not whisper in our ears. They proud to represent working people. Let's be straight up, okay? You can have different opinions about different people come to you, but, when you're making the decision in democracy, you represent people and interests and so forth, and we got to figure out how to balance those for the, what we think is the best interests of our constituents and the state. So, how do you make those kind of decisions? But I would say is that, just going back to what was presented at the panel and some of the conference afterwards, I'm a doctor. I like the idea that, hey, you know what, I'll just get paid something. No one's going to question what I do, et cetera. But the reality is that even if everyone's doing, quote, trying to do the right thing, we still need the organizational capacity to organize ourselves into systems, right? So going back to the behavioral health thing, it's not just enough to have a bunch of behavioral health professionals there. Someone has to help organize, people. It's not good enough just to have a bunch of primary care doctors there, right? Someone has to organize them into more effective systems so you can deliver effective care and quality care and cost-effective care to people with chronic diseases or other types of population, right? And if you're going to address equity, we can monitor, but then the question is, now that you find there's a problem, what lever are you going to use to effectuate that? So we know there's systemic racism, we know there's disparities in care, and we can say everybody just gets paid directly, but then what levers are we going to be using, therefore, to address those inequities, right? And how are those decisions being made, and what kind of incentives? And it's not because everyone's necessarily just chasing the dollar. It's also about the availability of resources and how much of those resources should be directed to what. And I think, so that's going to be part of the challenge in terms of, and that's why it's not just about the money part. I agree. It's about, the delivery system and what we're willing to, what we're going to support. And, is that overhead to organize waste or not, right? So yes, I want to minimize the amount of overhead and administrative costs. So the question is, what is that is necessary for us to do the organization, to do the monitoring? By the way, that costs money too, collect the data, analyze the data, and how much of this is, and some of it is trying to just, and then how much of it this is it just, doesn't bring much value back. And so we, decide we don't do that anymore. And so that's a dialogue that has to go back and forth. It's not, the answer is not actually that easy to come up with. So I think I tried to answer.
Yeah, no, that helped. I'll say what you sort of did for me is we have these lists of tools and dials. They do various things. However, they're used, some of them cost more money to do than others. And it's important, regardless of whether you have a direct payment system, a capitated system, you have these incentive-driven systems, that some of this will be required to monitor and make sure that we're delivering on what we hope to deliver. And the question is, how do you put them in some, not order, but understand their relative use and value in the system that we might create?
Well, fundamentally, this is like how we decide to distribute resources. right? I mean, part of the reason we're having this discussion here is there's a belief by many people, including, you know, that we spend too much on, and I don't disagree with them, on with too much of the resources devoted to the sector is to waste and administrative overhead. And so, for in fact, one of the big savings that we're hearing that people who say they want single payer is that we can get rid of the overhead, right? We can greatly reduce, and I'm not disagreeing with that there's a lot of like how to process the money, right? How to take the money that goes from the payer, from the employer or the patient, that then transfers to a health plan, that then transfer to maybe an intermediary, that finally gets its way down to the provider, and then what they do with that, right? So that we can trim that down, right? But then there's also some question when it comes down to whether direct payment or do we have intermediaries, is that as the money's flowing out, all right, the resources are flowing out, what's not only the monitoring, the oversight, it's then if you find, when you do the oversight, because if you're going to do the oversight, you've got to do something with the results, right? Otherwise, that's waste to me if you just monitor and not do anything. Then the question is, what levers do you apply, whether it's resources or others? What levers do you apply then to address the deficiencies that you've identified, right? So whether there's overspending somewhere or there's insufficient, there's disparities in healthcare. So it's not just enough to monitor and measure, but you also then need, well, at least in my mind, you need to do something about it, right? So therefore, what sort of tools do we use to then to address that? One of the tools, of course, is direct more resources toward particular things that we think would address that. Like, for example, this year's budget, we're budgeting $4 billion for children's mental health, right? And I think it's because we have a deficiency there, right? So how we have to make those kind of this. So we have to figure out how to make those decisions regarding the distribution of resources.
Okay. Thank you. I appreciate all the conversation. I'm going to speed things up just a little bit because I know there's a lot of people who want to speak and I don't want to shortchange our public comment time. Richard Scheffler, I wanted to yank you in. I do see the hands, and I'm going to stop asking questions and let people riff off one another in a moment. But Professor Scheffler, you and I have talked a little bit about integrated systems, managed care, its dominance in California. I want you to focus a little bit on some of the limitations you see with that payment model and where you think we can do better. And if you have ideas on how it might do better in those areas, especially in achieving equity and closing disparities, love to hear a little bit on that. You're on mute if you're talking.
Okay, thank you, Mark. Thank you. I was so enthralled by the conversation we've had so far and so interested in it. I'll try to focus on your question. There's been a lot of discussion about using capitated payments as a tool for integrating healthcare systems, and I do think they go hand in hand. And it's very hard to have an integrated plan unless you have a capitated system, because in order to do that, you need the funding up front, the amount of money per member per month, and then you can use that money as a budget to integrate your system. And I think California is a leader in this area. Probably now we have about 70% of the population already in some kind of capitated model. And we've talked about it's a big state, so there's a lot of variations on the kind of capitated models that we have. Some are full risk that includes everything for the patients. Some are professional risk, which deals only with what the physicians and other providers offer, but not the hospitals. There are those that have pharmacy benefits included and a lot. So it's not a one size fits all. But the general principle is to pay an amount of money for each enrollee. And the first thing one does with this is to make sure that the payment is fair, you risk adjust it. which says to the provider that if you have sicker patients, you get more money, which makes sense. I can tell you the limitations are this risk adjustment is not perfect. And it only accounts for so much of the variation in the health of the population, but it's better than nothing. It's a move in the right direction. And the risk adjustment, I think, has become pretty standard. To repeat again, it's far from perfect. There are ways of improving it. One can risk adjust after the fact. You can look at what's spent at the end of the year. And if a particular healthcare system has demonstrated that it has sicker patients, then you can think about compensating them more at the end. Correspondingly, if a system happened to get healthier patients, you know that at the end, then you can risk adjust their payments after the fact. But there's another great tool of risk adjustment, and it has to do with the fact that you can directly build in equity concerns in it, which I know is a fundamental building block of what we're talking about in California. And the way you can do that is to look at the patient population. To give an example, you can do this by area, zip codes, for example, or other measures of geography. And you can say in these areas, there is a maldistribution of income. There are populations in great need. And if we want the healthcare system to take care of those people in that area, as Sandra has pointed out, this would be population-based medicine. You're responsible for those people. Then perhaps you want to give them a higher payment for doing that. Because if you don't, it's hard for them to come up with the resources. So you can use the capitation formula and you can adjust it for the inequities in the healthcare system and the particular needs of communities. So I think that is a major benefit of using the capitation payment. It's very hard to adjust each fee for the the underlying economic situation and disparities in the healthcare system. And you can also use the capitated payment system to pay more for systems that deliver a higher quality. And now we've made great strides in quality measurement. I'm sure you're aware of that. 10 years ago, people talked about it and the measures were crude. Now we have measures that I think are much more acceptable. Again, they're not perfect, but there's a number of them that work pretty darn well. We have quality ratings, and we can attach payments and the way providers are dealt with to the quality that they provide to their patients. And I know another goal of our system is quality care for everybody, just not affordability, but affordability of high quality care. And California has the healthcare system, the providers, the hospitals, to deliver the highest quality care in the United States, if not the world. We ought to pay the people and pay the systems that deliver that. So hopefully, Mark, that's a short answer.
No, it helps, and appreciate the tutelage on risk adjustment and its impact and how it's used in the capitated setting. And your point about the integration can't happen if the money comes after, I think is just an important point that we should keep thinking through. All right, I'm going to go to some people with hands, and then Dr. Rothbaum, I'm going to pull you back in on community health centers and their role in the systems delivering accountability. Jim, Dr. Wood.
Thank you, Dr. Ghali. And just I'm going to go back to some comments that Dr. Hernandez said earlier on about behavioral health. So we'll just break that into mental health and substance abuse, and thinking about also preventive care. So we have a very uncoordinated system. People who often have mental health issues may also have substance abuse issues, but there's not much coordination between that. And some of those same people also are chronically homeless, and there's no coordination between that. And so one of the benefits that you see potentially with a single payer system is more money around some of these other issues to coordinate things better. I almost feel like, I think for me, a lot of this is around the quality and coordination of care that we put together. We don't spend enough on prevention, so we spend a lot more on chronic disease management. We spend very little on diabetes prevention, but yet we spend billions of dollars in the Medi-Cal system to treat diabetes. And so if part of this is just, it isn't just about a payment system and a delivery system. It's about a coordination system if we're going to have the health outcomes that we're really looking for. The final piece that, I want to be brief here, is really important, and that is our lack of ability to exchange information. So those same people seeking mental health care are not always getting that information to their primary care doctors and to somebody else, because our system is incredibly fragmented. And so we ought to have a much better system to be able to coordinate so that everybody who is related to the patient can actually have access to that information. And if you happen to be out of the area, some other doctor should be able to have that access to that information in a timely way to get the best quality care to someone.
Jim, I think you're doubling down on some of the dials or tools and sort of suggesting some of really high priority. Will, you had your hand up, you had your head nodding. What say you?
Yes, thank you, Mark. What say I is that a single stream or a universal stream of funding doesn't necessarily resolve the needs and the discontinuities. That sort of integration function is something that has to be performed. I mean, we have 14 million people covered in Medi-Cal in California. A small subset of that group we've spent a lot of time this year looking at. That's the foster care population, 60,000 kids, more or less, all of them covered by Medi-Cal. The discontinuity in their receipt of behavioral health services, some of them are in fee-for-service, some are in managed care, et cetera, really runs from the fact of a lack of a planned, focused, integrative care system on the ground that meets their needs. Take that out to all the other populations of relatively high need that we deal with, in the Medi-Cal system, and whether it's one stream of funds or several stream of funds, it's not going to make a great deal of difference unless we have the integrated systems and unless the payment systems are supportive of population health outcomes, not necessarily the individual's health outcomes, as Peter was saying earlier, but population health outcomes. So for just going back to my small example of the 60,000, not just are they receiving units of service, are they receiving 5 visits in a year, but is it supporting their placement stability? Is it supporting their return to family? Is it, looking really at what we will define as the desired population health outcomes for that population. And so key thing I just want to emphasize is whether we're talking about intermediaries or we're trying to avoid using that word, the entities that will do the integration of care and the care coordination is, to me, the indispensable piece of a system of the future that we want to build.
Great, thanks, Will. Rupa, before I go to you, I want to pull Bob in. Bob, last time you spoke about really, I love the comment about community health centers and their role. They're on the front line like no other. They're not the only ones, but they definitely have a share of the market on trying to support low-income people who face huge health disparities. How do you see them as players and supporters of an accountable system in this unified way that we've been talking?
Yeah, thanks, Mark. I'm not sure I have a precise answer to your question, but I'm really today's a good day for me to just sort of soak in observations from my colleagues. And thank you so much for teeing up the Vermont experience. I guess I would say that I'm having here's where I'm at today. I'm having a hard time reconciling how we go back to a fee-for-service direct payment model and still advance these issues that are so absolutely critical for us to get to, issues of integration, issues of, thank you, Will, for mentioning population health and community health, issues of equity. And so I'm really struggling with the absence of, and the reason I mentioned community health centers, as I think about intermediary roles for these issues of integration, of equity, of population health, it's not so much, at least for me, that intermediary is equated with evil. It's what value do they bring and what values do they hold? Do they express and articulate the values that we want for the system and for the communities we care about? And then what specific added value do they bring? And the reason I mentioned community health centers, it's one of those, our system needs a lot of help and needs a lot of work. There are some things in California that we do pretty well that we can't leave behind, and we should try as best we can to incorporate into this model going. Community health centers and how they work is just among them because of the value they bring and the values they hold. And so I know they're not set up to be an MSO for a statewide financing system, but we should figure out a way to extract what they've learned about cost control and integrated care and prevention and equity and diversity in the health professions. And they've evolved beautifully over the last 30 years from your basic garden variety community free clinic to a business model of health that expresses the values of communities. And so I don't know exactly sort of what that means for them sort of going forward, but I sure as heck would not want to see them left out and left behind. And I think we should begin to codify and identify what are those elements of our system that are working really well from the standpoint of both value they bring and values they hold, and that we want to bring along into the system. And I'll continue to listen to my colleagues and see if we can incorporate that going forward.
Okay, thanks, Bob. Just looking at the clock, and I'll go to facilitation school right after this to make sure we can stay better on time, but help me out, folks, with a minute or two comment, and I'm going to try to pull those especially who haven't had a chance to speak. But Rupa, go ahead.
Thank you. I want to echo just what a wonderful dialogue this has been today. I've learned a lot from listening to everybody, a lot of great comments. I do think I just want to celebrate the work that we're doing here right now, because what we're doing together is imagining a system that doesn't yet exist. It's not Taiwan, it's not Vermont, it's not Kaiser, it's not Blue Cross Blue Shield. It's something new. And I think part of our fumbling is not understanding exactly what that will look like or what that would be. And my hope is that we, in our process, that we can have that accountability that we seek to have in the healthcare system that we're trying to create and imagine into being. And so my speaking to lobbyists was about private healthcare industry lobbyists, not labor lobbyists and not lobbyists for healthcare access. I'm all about them getting up in, Sacramento as much as they can. I just think about the role of community health clinics, what Bob was just saying, as being almost like an emblematic model of what we could be doing in terms of hyper localizing and understanding the communities that we serve, and then scaling not in terms of a ginormous, singular focus, but something that would target the specific concerns of, up in Lake County, the specific concerns in East Oakland. And so I see the community health clinics as being maybe vital in pulling into some of the more successful or groups that we know of that work really well into this conversation about what works and what doesn't. What I do think about private health insurance is that I don't think we need to continue the financial abuse that they enact upon the people of California and upon the doctors and the nurses, frankly, with what we've seen with COVID. We do not need actors in our system that will be extracting healthcare dollars from either the payments. All that money should be going to improving healthcare. And I think that I was very interested in hearing Richard's comments about capitation. It would be amazing to close the wage gap for female providers in healthcare. And there's plenty of data that shows that you're more likely to survive a hospitalization when you have a female doctor. So it would be great to look at some of these models and how they could advance equity within our workforce as well. So I just wanted to say thank you to everybody for your contributions today.
Thanks, Rupa. I want to pull Jenny you in and your work. I always am so grateful you're here because of the work on PACE and one of the early models that thought about social drivers and care in a number of different settings and accountability and quality and measures, and just what in that system, like Will's example of a small population, it's not a cover everyone system, but it has some unique aspects, and just love to hear your experiences and thoughts on kind of what worked on accountability there.
Well, thank you, Secretary Galley, for your requesting this. As I've been listening from Governor Shumlin to thinking about, Richard, your describing of managed care. My particular area of history is working with older adults who have multiple conditions at an average age of 83. And I did that for about 25 years. And that context of the population in terms of population care, older people with disabilities and cognitive losses. And these would be people who would be in nursing homes, but for a program like this. So I just wanted to set the context. But cutting right to it, it's a program that is a managed care program before the word managed care was coined. I started there in 1980. And so, and this was talking about risk management, talking about risk adjusted payments, bundling payments from both, especially starting in 1983, from both Medicare and Medi-Cal into one system. And that we, the provider, this community organization was responsible for all that care to help a person who, if you imagine being in a nursing home, would normally be in a nursing home facility, have Medicare benefits for going to the hospital, have Medicare physician benefits for taking care of them. Well, we did that wipeout and basically took this one central amount of joint funding from the feds and from the state to provide everything that would help the older person be able to maintain their quality of living in the community, despite the fact they're certified to be in a nursing home. And with that comes in the terms that we call care coordination, care continuity, care management. All of that is wrapped into this because our goal was to help that person live his or best life. There's a new phrase and program term called the 4 M's of age-friendly care relative to their I'll say the words first and say how this comes together. It's mentation, medications, mobility, what matters to people. And this framing is what is the end goal or the outcome of what we're looking at. because we have to help support people's continued functioning as well as getting around mobility. The fact that most older people are on, especially in nursing homes, are on a myriad of medications, some of which frankly are both not appropriate and often overprescribed. Mentation, changes in people's abilities over time, especially with the 85+ population, about half, between 40 to 50%, have cognitive loss, if not dementia. And what matters to people, which goes back to what are the goals? What is it that people want to do? And so these are people who enter a program voluntarily, managed care program as it's defined today, and is not about scrimping care, but it's providing the kind of care that people are looking for. And we talk about loneliness and things like this. We have socialization, but the right medication, right medical care, and a team of people who work together, from the driver who picks you up and tells the nurse or the social worker or the doctor that something's different, that gets picked up. So it's a holistic program, and it sounds very high touch. It is, but now technology is also available. With COVID, all this stuff turned on a dime in terms of remote care. Bottom line is the flexibility in this program. And I think, Carmen, this whole idea of, really attending to the needs of what people need and want and their family members is built into this model. So it's up and down throughout California now, but it also, and that's how I know Andy, worked with him in Congress to help pass this legislation. This particular program is called PACE, the Program of All-Inclusive Care to Elders. It is now in 31 states, but there is financing risk adjustment, there's focused population, team-based care, and all the C's of better care that we have. And we take care of people till they pass away because of the sheer nature of when they come to us in the program. So it just gives you a different look of what managed care can be, and the fact that it is centered on the individual, but accountable to clinical outcomes in terms of oversight. So this is an example of how care can be designed and received and accounted for, and know that people have a voluntary choice in this. So thank you.
Thanks for reminding some of us who knew it, but letting all of us know, because I think it had some terrific outcomes. I want to go Carmen, then Sarah, and if I have a few last minutes to pull people in before we go to public comment, I will, and try to wrap it up. So be brief if you can. Thank you. Go ahead, Carmen.
Yeah, so I think, from what other folks were saying, I just wanted to make a little bit of some, make sure we're all on the same page here. So when we're talking about direct payments model, I want to be real clear that it doesn't necessarily mean fee for service. And the system that I was describing with institutional global budgets, so those institutional global budgets would be paid quarterly to hospitals and other institutional providers. And then the fee for service component would only be an option for individual providers, which roughly would represent about 20 or 30% of the care that's being provided. But then those individual providers would ideally have the option of negotiating a salary with the system. So, I think there are ways that we can creatively think of alternative systems that from managed care where there are financial incentives and we're relying on businesses to provide care for patients. And I just wanted to, as kind of a level setting type of when we're thinking about the different systems, and just in response to what Jenny was saying, that unfortunately the fact of the matter is that managed care organizations, they're not all like PACE, and we can't rely on different business interests to care for patients. And I think that it's really important to understand, like even our Kaiser that a lot of people like holding up as the shining example of managed care. Just last week there was reporting on Kaiser of using step therapy guidance to limit access to groundbreaking postpartum depression medication, possibly because it's very, very expensive. And, it's been very difficult for women who are receiving postpartum care with Kaiser to get this medication. And Kaiser also has had the largest fine ever from DMHC, $4 million for limiting access to mental health care. So I think we need to understand that, sure, we might have one or two managed care organizations that might have some business model that actually doesn't, is operating at costs and isn't trying to limit the care of their patients. But for the most part, corporations, whether they're for-profit or nonprofit, their business is to make money. And I think we need to be absolutely clear that that is what we are asking for when we're talking about managed care plans. That's the person, that's who we'd be asking to manage integration and coordinate care. I think for me, the people who should be coordinating care are primary care physicians, people with licensed medical in licensed medical professions, and people who are actually treating individual patients, not businesses, not corporations, not people who have financial interest in what care is provided to the individual. And I think, I think it's problematic to assume that we can only get integrated care through massive integrated corporations. We don't need legal corporate structures between providers to get to integration.
Thanks, Carmen. It's helpful. I look forward to trying to summarize this in just a minute, but Sarah, go for it.
I'm a little discombobulated because I think there was an earthquake in Sacramento. Was I the only one? Okay. I was like, am I going crazy? All right. Sorry, that threw me off.
You all held it together incredibly well.
I think I was the only one who fled.
Wow, I was like, no one else responded. Maybe I imagined it.
Yeah.
Anyway, I wanted to say, I hope we have a chance for Professor Shao to talk about what I thought in his paper, the options. I thought option 1, option 3 in the paper on Vermont were fascinating, and it might be helpful for us to dig into a case study in the work that's already been done on those models. But I also was struck on the last meeting we had, there was a public comment where they talked about financial intermediaries, which I thought was a really good description. That in a single payer system, one of the advantages is that we can get rid of these middle people and these kind of risk-bearing or financial intermediaries, the health plans, the insurance companies, where they have a financial incentive to deny care and to manage care in a way that is profit-driven for themselves. That said, I do think we need to distinguish between good managed care that actually does manage and integrate care and promotes equity and high quality care and even adherence to medication and adherence to doctors' guidance, which is really incredibly important. And especially important, I think, where in California, a state where we have so many different languages that are spoken, so many people that have English is not their first language, immigrant communities, and huge health disparities. And so I think it will be interesting for us to imagine what that looks like. A lot of my experience has been with labor management trust funds, which are both fully insured, but then have a self-insured side where we're paying claims directly. And so we look at what's happening, and you can have really high quality care. Like we have some doctors where they're doing really incredibly good C-sections, but you see that they have a rate of C-sections, elective C-sections that are 20% higher. And you see that they're in one case, they were all near a golf course and scheduling around tea times, or doing it on a Friday so they wouldn't have to come in on the weekend. Or just like, there is, I think, a need to make sure that there's some accountability for physicians in the care they're providing, and physicians might not be the appropriate ones to coordinate care. They might, it might be that we want to free them up from administrative burdens to actually spend more time with patients. And so how do we figure out what are the best institutions for coordinating care, for making sure that people have a guide through the system, and a guide that is linguistically and culturally appropriate, and can be in line with health promoters, with navigators, with maybe less expensive parts of the system that increase adherence, and, to Dr. Pan's point, who are maybe helpful in saying, like, you don't really, just because you saw that ad on TV, you don't really need that drug, or the generic is better. Or actually, I know it sucks, but you don't need spine surgery. You just need to go to physical therapy every week. And so how do we build in care coordination and integration that also builds in culturally appropriate, reducing health disparities with a preventive aspect? And maybe, like Dr. Maria said, this is something that we don't have in our system, but we build it in. And I think the advantage with a single payer unified financing system is, to Dr. Wood's point, we can also have a unified information system, which I think makes accountability so hard now, because not only is it a fragmented health system, it's a fragmented information system. Like, we don't have any oversight. There's no state body that's looking at the entire system as a whole. And that's part of our challenge. And hopefully single payer will make that a lot easier. Yes, I think that's, I have a lot more to say, but I'll just stop at that and get to public comment.
Yeah, I wanna get there as well. So in a minute or two, try to just close us out, and then Karen, I'll go back to you and facilitate public comment. Again, hopefully the commissioners can stay throughout it. I know we've lost one or two pre-planned folks who had to take off a little early. First off, I think we have successfully not had a conversation just about one versus another. I think we really did get to the attributes of systems that could drive to what we hope to see a healthcare system deliver ultimately. I think we stretched ourselves a little bit on the unified financing approach and kind of the levers and dials that we might have coming out of it. I liked, Rupa, your point about new, and I would just say it's new and different, right? And part of the challenge is trying to make sure we're not applying the same dials and levers to the same old system, but we're thinking about how they get applied to the new system. I want to come back to a comment that Bob made about values and value. I think we also, and I'm not struggling, but it's probably fair to say struggling right now. You know where we are with vaccinations in the state. We got all the easy people done. Most of the people, there's some people who've come along and decided that, yeah, this is the time. But right now we're seeing a variant start to really take off. It's much stickier and transmissible. More unvaccinated people are getting sick, and it's on the backs of communities that have already been disproportionately impacted. And this last mile of vaccinations is hard, in part because of the system we have to work with. And when I think about the value that community health centers, for example, and other real deeply connected community-based providers bring, it's because of their values, right? And Sarah, to your point about the diverse workforce, I actually like to think, and this comes from time running clinics in Bayview and South LA, that some of the most valuable individuals were the ones who walked to work, didn't drive to work, because they understood the community and how it ticked. And right now, I wish in this state we had a bigger army of folks who walk to work to really help work on this vaccine issue, because it's no small issue. And I've had a chance to talk to some important organizations about how we get to this. But when I think about this idea of integrated care, I also think about all these levers and dials that we might have, and the opportunity to figure out how our payment system, not just is it a direct payment or is it a capitated payment? Is it a global payment? Is it an upfront payment? Is it a retrospective payment? Is there some aspect that is, as you said, Richard, not a true up, but an assessment at the end to make sure that those who had more risk and more work didn't lose their shirt on it? I mean, these kind of tools, how do we bring these opportunities together? And I think we've set ourselves up to have additional conversations about how we blend these different opportunities of the attributes, the dials, the levers of the system we hope behave well and work well, and how we structure the outflow of dollars to optimize the use of those levers and dials. And I think as I work with the consultant team to think about our future conversations, we'll try to marry those. Before I stop, I'll just say thank you to all of you for helping the quote panelists that made some opening comments, Governor Shumlin, to all of you for participating in the conversation. As promised, we will be sending out not minutes, but some summaries of this conversation and our last one for all of you to be able to review, make some comments about them, so that we can really see how these conversations build up to that final report. So we have 2 meetings this way under our belt. We're going to try to put those in summary documents. Look forward to your feedback and kind of building on those as we go. Because we wrap up so quickly at the end of public comment, just again, thank you. I hope you all enjoyed the meeting as much as I did, and I look forward to connecting and getting feedback between now and our next meeting. So with that, Karen, do you mind? I see a ton of hands up. Looking forward to listening. Go for it and facilitate the conversation.
Thank you, Secretary Galley. So as many of you can see, we are now taking virtual raised hands, and we'll invite verbal speakers one at a time. Please state your full name and any affiliation that's relevant to this conversation. We'll give you 60 seconds so we can fit in as many speakers as possible, and I'll say thank you when your time is up and we'll move on. We'll be opening up the chat feature now as well for written comment, and you can always email your comments to healthycaforall@chhs.ca.gov. With that, I'm going to invite Peter Shapiro to speak.
Okay, I'm with the California Alliance for Retired Americans. I'm on the board of Healthy California now. I want to, Governor Shumlin kept emphasizing the need to have cost controls built in. You can do that by eliminating waste, or you can do it by rationing care. Right now, we do it by rationing care. It's not working very well. We have a very costly system. I've been with Kaiser really all of my working life. I have an ambivalent relationship with it. When I first started out many years ago, I was attracted to it because their model features, it's easy to navigate, the doctors collaborate well, and the emphasis is on preventative medicine. Back when I first joined there, they marketed themselves as the cheapest plan on the market, and it showed in the quality of care they gave. It was perfunctory at best. It was downright negligent at times. Their doctors revolted in the 90s and demanded a higher standard of care. So now they have it, but they also have higher premiums. They have introduced deductibles, some of which are quite large. They've got, I believe, 26 plans on the covered California market and 11 more in the small business market. Some of them charge deductibles as high as $12,000 for a family plan. How on earth are you supposed to reconcile a commitment to preventative care with a $12,000 deductible, which discourages people from getting it?
Thank you, Mr. Shapiro.
Thank you.
Thank you very much. Next, Mary McDevitt, please go ahead.
Yes, thank you. Can you hear me?
Yes, I can.
Yes, I'm a retired physician living in Sonoma, California, and I was really appreciative of the governor's presentation. And I was impressed that he started out talking about financing and the importance of federal dollars. And then when he went on to waivers, we know waivers are very complicated. He talked about both financial waivers and program waivers, and then sort of made a blanket statement that he's gotten all these waivers. I need clarification because the press at the time pointed out that the Affordable Care Act in the law precluded any state asking for a waiver until 2017. And the press went on to say that the governor went back to Washington to see if he could get that changed and was unable to. So my question and the clarification I would ask, did he actually get the Affordable Care subsidy dollars from the federal government? And if he did, or if he would that have made it unnecessary to increase sales tax and employer taxes? Thank you.
Thank you. Ryan Skolnick, please go ahead.
Yes, my name is Ryan Skolnick, and I gotta say, this commission is having the wrong conversations. The primary driver of cost is not the fee-for-service boogeyman, it's administration. A full third of US healthcare dollars go to administration. Capitation won't fix that. We've heard about how much better things will get if we just did more capitation, a reimbursement model literally predicated on the reduction in denial of care. We heard a commissioner talk today about how patients can't be trusted to make their own decisions about providers. We're talking about forcing providers to juggle their care obligations with their personal financial interests. This commission is focused on everything except for the whole point of the healthcare system, care. Our for-profit system has created millions of uninsured and underinsured Californians, while the insurance, drug, and hospital corporations enjoy record profits. Create a single entity, and you curb the cost growth by negotiating the lowest drug prices and providing the most efficient, high-quality care possible, as outlined in AB 1400. Take that bill up, model it, use it to inform your report. It'll be a much more fruitful use of your time.
Thank you. Bill Honigman, please go ahead.
Thank you. Can you hear me?
Yes.
Thank you. I would like to add testimony on the subject of integration and care coordination, in particular as regards to HMOs. I'm a retired emergency room physician who practiced in the provider group model known as Kaiser Permanente for over 30 years. And I can tell you that the provider side of that organization was excellent and exceptional. We were entirely focused on the quality of care delivered to our patients using scientific, evidence-based, shared best practices in interdisciplinary teams to keep our patients healthy, true to the original idea of a health maintenance organization. However, the side known as Kaiser, specifically the health plan business side that limited resources to us as providers, was where all our frustrations were. During my tenure there, insurance products like co-pays and deductibles were introduced to entice market share that undermined our practice model of keeping our members healthy. That insurance side of Kaiser is the part that needs to be reformed to exclude that third party or financial intermediary, as I believe you are calling it. Without the commercial insurance function of Kaiser Permanente, I'm sure it could carry on exceptionally well in a single payer or unified financing system. And truly thrive. Thank you.
Corinne Frugoni, please go ahead.
Thank you. I'm a family physician up in Humboldt County in Northern California, where it was mentioned that there's a dearth of providers. I would say under a single payer system, there are ways that we could get many more doctors up into rural areas where there's a dearth by providing better salaries, by making it much easier to run a practice. There's no perfect form of payment. What we need is diversity of payments, including fee-for-service, which is not the driver of the expenses. As is shown in Canada and other countries that do have fee-for-service, that is not what causes all the expenses. So we need to look at that evidence. There was a mention of quality that there's great quality metrics. Well, look at our statistics. They're terrible in this country. So I don't think the quality metrics that have been made really are working. We need to set up a single payer system where everyone has equal access, and then look at, with an oversight that can look at fraud, that can look at practitioners that are not providing quality medicine. Right now in medicine, there are a lot of doctors that are stepping out of the system to provide concierge medicine. I'm not a fan of concierge medicine, but I understand why doctors are doing it because they want to provide that quality care, which we can do under single payer.
Thank you very much. Pilar Schiavo, please go ahead.
Hi, my name is Pilar Schiavo. I'm an organizer for Healthy California Now. I just wanted to, express my appreciation for Governor Shumlin. I think that he made some really important points, and I think important points to be heeded right now at this moment in time. And I think especially in the current political context, I think he raises important points about the need for us really to move as quickly as possible at the federal level as we can, that this is not the time to wait. We all know that the 2022 midterm election is coming up, and traditionally there's been a shift in terms of, the control at the federal level in those midterm elections, that as much as we can do and as far forward as we can get in terms of a waiver process right now is really critical. I've been organizing on this issue around single payer for a decade now, which is hard for me to believe. And when I first started organizing around this 10 years ago, I remember seeing old information of when there had been a campaign to get LA Unified School District Board to support single payer, and they actually costed out how much they would save with it. And it was millions of dollars. And it's hard to think about how much would have been saved if we had actually done it then. And now is really the time for us to do it. And so I hope there will be urgency around this movement forward at the federal level.
Thank you. Michael Leighty, please go ahead.
Thank you, Karen, and thank you, commissioners, for a deeply engaging discussion. I think we should name the American healthcare industry as the defining name for what we say is a non-system. And that industry has created things like narrow networks, which are promoted by Covered California. It's created things like the underfunding of Medi-Cal, which limits access to specialists. These are drivers of inequities, these high deductibles that people have mentioned. And so when we talk about attributes of the system, we need to first, as others have said, take out the administrative waste, take out the profits. It is a distraction to focus on healthcare workers' salaries. The driver of high prices is the fact that the prices are unregulated, and single payer financing, of course, provides the means to do so. Dr. Galley has talked about attributes of the system. We need to be clear. A key attribute has to be guaranteeing access to healthcare with no administrative or financial barriers to securing services, establishing a single standard of therapeutic and equitable care, providing services based on patient need and medical necessity as determined by the provider, not by algorithms, not by protocols. Thank you.
Very much. Beatrice Sosa Prado, please go ahead.
Good afternoon, everyone. This is Beatriz Sosa Prado from California Physicians Alliance. And this was a great discussion about unified financing. It's a conversation that you all need to be having. I also want to say that I appreciate all of the comments from the commissioners, Dr. Ghali and Governor Shumlin. California can create a healthcare system that is socially just and a system that is universal to ensure quality and accessible healthcare for all Californians. And I'd like to remind everyone that this is CAPA's mission. CAPA is a statewide nonprofit organization of progressive physicians and healthcare professionals who advocate for a single payer system and an improved healthcare system for all. Thank you.
Thank you very much. Maria Behan, please go ahead.
Yeah, hi, my name is Maria Behan, and I co-chair the Healthcare for All Working Group here in Sonoma County. I'd also like to, oh, didn't I start my video? There we go. I'd also like to remind everyone that of something that Rick Cronick, he presented some pretty dramatic numbers 2 meetings back. He estimated that if California had unified financing that used direct payments to providers, it would save $42 billion on administrative costs in a single year. Leave what he termed health plans / health systems in the mix, and those savings are more than halved. To raise a related question, if a bully were ripping off a child's lunch money, what would you do? Would you end the outrageous extortion or take up a collection so the community covers the bully's demands? I hope the commissioners use their expertise and insight to disrupt the cycle that enables for-profit intermediaries to prey on patients and taxpayers. Thank you.
Thank you very much. Tracy Rattray, you're next.
I'm Tracy Rattray from the California Alliance for Prevention Funding. Thank you, Secretary Ghali and commissioners for today's discussion. Many on today's call have mentioned the importance of outcomes-based payment and population health in redesigning healthcare delivery. Investing in health equity and community-based prevention programs is one of the best ways to achieve these goals. Just one example, the unequivocal success of tobacco prevention programs. Much of this success has been driven by partnerships between the state and community-based organizations working together to reduce youth access to tobacco, increase taxes on tobacco products, and prohibit predatory marketing and other risks for tobacco use among communities of color and low-income Californians. The result? Over 1 million California lives saved and $134 billion in healthcare costs avoided by preventing chronic conditions such as heart disease, cancer, and stroke that are associated with tobacco use. Imagine the decrease in health inequities and healthcare costs if we invested at the same level in community-based strategies to prevent diabetes. I'd like to thank everyone on today's call who shares this vision, especially those who have supported AB 1038 and an accompanying budget request to create a California Health Equity and Racial Justice Fund.
Thank you. Patty Harvey, you're next.
Hi. My name is Patty Harvey. I'm with Healthcare for All and Physicians for a National Health Program in Humboldt County. And I'm with Rupa, Sarah, and Carmen on the issue of intermediaries, and whenever I hear the words business model for those intermediaries, I get very nervous. I wish that I were beating a dead horse here, but I think it bears repeating the words of Wendell Potter, who is a former vice president of corporate communications at Cigna. And he wrote a book called Deadly Spin. An insurance company insider speaks out on how corporate PR is killing healthcare and deceiving Americans. And what he said really bears repeating over and over. Our health insurance companies are not essential. They don't treat anyone. They don't prevent anyone from becoming sick. They don't take you to the hospital and make sure you take your pills. They don't discover medical innovations. They're simply middlemen we don't need. And in the industry, we always dreaded the day American businesses and patients would wake up to that reality. That day has come.
Thank you, Ms. Harvey. Appreciate it. Bryn O'Neill, you're next.
Thank you. Bryn O'Neill, NNU. Commissioner spoke about care coordination. Now, the insurance industry often uses terms like care coordination or managed care as euphemisms for care rationing, but we can make sure that a system provides for services that genuinely help patients navigate the medical system. It's important that primary care physicians and nurse practitioners who have the clinical training necessary to know what kind of care a patient needs are the ones coordinating their care. We should be training people from diverse communities to be culturally competent licensed professionals who speak different languages, who patients can trust to play that role, not creating a two-tier system where only the affluent get trusted coordination from actual licensed providers. To get to equity, we need a massive educational program to train more professionals for medically underserved communities. A single payer system is best suited to identify gaps in the workforce and direct resources to remedying them.
Thank you.
Thank you.
Thank you. Craig Simmons, you're next.
Hi, I'm Craig Simmons, and I'd just like to offer the commissioners a couple of questions. One is, if there would be consensus for the drafting of a ballot measure for implementation of a payroll healthcare tax to facilitate a single payer system. And if the answer to that question is yes, then if there would be consensus for standardization of costs, which seems to be a big topic, especially with Peter Lee. And I've had some experience in both of those areas, and I would like to offer my services either as a staff or consulting position to get single payer healthcare tax implemented and voted on by the people of California. Thank you.
Thank you very much. John Douglas, you're next.
Thank you, folks. I'm John Douglas, Santa Barbara, California. I'm a member of DSA, Santa Barbara, Healthcare for All California, Santa Barbara, and Physicians for a National Health Care Plan, started by our wonderful Nancy Greep, Dr. Nancy, here in Santa Barbara. Everything is contained in AB 1400. It's a well-written bill with the possible exception that, of course, there should be specified that doctors serve on the governing panel. I agree with that point of view from doctors in California, from what I've heard. We are going to be meeting with Salud Carbajal, our congressman, next week to urge him to co-sponsor the road on a state-based universal health care bill so that we can ease the way for the waivers. Thanks for letting me speak. We need health care now. We need single payer. Thanks.
Thank you very much. Philip Kim, please go ahead.
Okay, hey, thanks, Karen, and hello, commissioners and fellow single payer supporters. My name is Philip Kim. I'm in Sacramento with the California Nurses Association. As Professor Xiao told us last month, any system that uses a so-called hybrid model with competing insurers and corporations that make money off of managing your care would create tiers of healthcare and lead to unequal access and higher costs. And that goes against the equity goal everyone here has agreed on. Hybrid models use health plans and other risk-bearing entities to divide up the risk pool, while single payer has a single risk pool, everybody in, nobody out. And in a single risk pool, we as a society protect the most vulnerable. A multi-payer divided risk pool would require risk adjustment, which has been tried extensively and proved to be unreliable. It would encourage risk-bearing entities to cherry pick healthy patients, find ways to drop the sickest patients, and incentivize under-treatment. We don't need that. A multi-payer model rewards corporate consolidation and punishes small independent practices who cannot manage the fluctuation of risk in a divided pool. So what we really need is a single payer system like AB 1400, a system with far less administrative costs that's not profit-driven, where providers will be able to focus on patient care. And as far as care coordination goes, as Carmen said, much of that can be done through primary care providers in a single payer system where everyone can see a doctor and there are no restrictive networks.
Got to move on. Thank you. Zach McDonough, please go ahead.
Hi, yeah, my name is Zach McDonough. I'm from the Silicon Valley Democratic Socialists of America. And I put on a comment last meeting and at this one, and it's just like between Senator Richard Pan, Assembly Member Jim Wood, like you just look at their donor records and their comments at these commission meetings and history of what they've done in their like positions. And I don't understand why they're part of this commission if they're just going to try to talk about like why private insurance and private healthcare and everything that's the way to go. Like we need administrative oversight. You know, he went after Commissioner Comsty today. I thought it was really inappropriate. You know, she had some really good facts and he just made circuitous arguments for like 7 minutes about how money needs quality. And that's why we have admin. And it's just like, I don't really see what the deliverable of this commission is if we have people like this involved that are going to detract from the conversations that need to happen. I just don't want my family to die. I don't want to die early. I want everybody in California to have guaranteed health care. Thank you very much.
Thank you. We have time for 2 more. So if you are further down the list than 2, please begin to consider writing your comments in chat. Isabella Story, please go ahead.
Yeah, thank you, Isabel Story. I really want to thank you for focusing the deliberations today on single payer, coordinated healthcare. And while I think it's important to consider many options, I believe the example of Vermont that we talked about has limited application in California. Besides other differences, it may just be as valuable an example of what didn't work. Single payer was never, oh, start my video? Okay. I don't have much lighting though.
It's okay. Please go ahead while you have time.
Okay, all right, sorry. So single payer never happened in Vermont. And that's because the corporate health industry was able to block it to preserve its profits. There was a 3-year delay between adoption of the policy and then consideration of the financing, which led to a political failure. So I would just advise considering both of these policy and implementation and financing at the same time.
Thank you. And Ruth Carter, you'll be our last speaker. Please go ahead.
Hi, thank you, Chair Gali and commissioners for this very important meeting. I am chair of the California Democratic Party Senior Caucus. And as you may know, our party has been a supporter of single-payer healthcare for a long time. We can all agree that our healthcare system is not working effectively and is fractured and broken. Many of us, including me, could not wait until we were 65 and eligible for Medicare so that our individual medical costs would be kept under control. While Medicare has some problems, not the least of which is the privatization of it through the Medicare Advantage plans, which also cost government much more. Medicare is a model that has worked since July 30th, 1965. There are no intermediaries whose goal is to be profitable. To me, it's unconscionable that insurance companies have made their biggest profits in history during the pandemic, and so many people. No provider or intermediary should be incentivized to realize profits by withholding needed services. Thank you.
Thank you. And Secretary Gali, I turn it back to you for a few seconds to wrap it up.
First, thank you to the public for sticking with us, sharing your thoughts at the end. To all the commissioners, again, thanks for your participation today. A lot of rich conversation, and I look forward to our next meeting and the work in between now and then. With that, take care, enjoy the rest of your evening, and we'll see you soon.